department परफेक्ट है।
A very good morning, respected speakers, organizing committee, and all the participants. I, Dr. Megha, and I, Dr. Rashmi, will be hosting today's webinar. Let us begin by praying to Goddess Saraswati before we proceed with today's webinar. Saraswati, Namastubhyam Varte Kamrupini Vidya Vidyaram Karishyami Siddhirbhavtu Me Sada. We invite our head of the department, Dr. Monali Shah, to welcome and give a brief introduction about the topic of the today's webinar.
Good morning, everyone. On behalf of Department of Parodontology, I welcome you all for this national level webinar on radiographic interpretation for implantology. We all know that implant placement requires extensive treatment planning, and we have 2D as well as 3-dimensional view to correlate the surrounding area and structure and to check the quality of the bone. Today, we shall be learning in detail about how these images will help us to interpret better for treatment planning before implant placement, during implant placement, and even during the follow-up period. We also will learn about dynamic navigation system using this radiographic images. To enlighten us on this, we have eminent speakers, Dr. Sanjay Jain and Dr. Mayur Kaushik with us. I extend my warm welcome to both the speakers. I hope you all will have a great learning experience and this webinar benefit you to have a better understanding regarding radiographic interpretation in implantology. Welcome you all. We will be starting the webinar now.
Thank you, ma'am. We'd like to share some instructions with you before we continue with the lectures. Our webinar will be streamed live on YouTube simultaneously with the Zoom meeting. So if you are unable to attend the meeting, please use the link provided to access the live stream. For duration of the webinar, all participants are requested to turn off their microphone and video. Feel free to ask any questions about the topic in the chat box or in the YouTube's comment section. And by the end of each presentation, we'll do our very best to answer your questions. Now, let us move on to our first session of the day by Dr. Sanjay Jain. He completed his BDS and MDS from the SDM Dental College and Research Center, Dharwad. He did MLD from University of Vienna, Austria, and MCT for Dynamic Navigation from Jain's Dental Care. From Navigation from Canada. He has teaching experience of 18 years. He is currently working as a lead dental surgeon at Jain's Dental Care, Pune, and as a consultant at Aditya Birla Hospital, KEM Hospital, Pune. He has conducted various laser and implant courses and hands-on. He has been invited as the speaker at the international conference, lectures and hands-on at China, Sri Lanka, UAE, and Malaysia. He is the only Indian invited to deliver main podium guest lecture at First Asian Pacific Division of World Federation for Laser Dentistry conference held at Beijing in November 2019. He has several national and international publications. We would like to invite Dr. Sanjay sir to kindly begin his session.
Thank you very much. Thank you, Dr. Monali, for this kind invitation. And I'm so happy that I'm at the prestigious KEM Shah Dental College.
You are not audible.
Am I still not audible? Just a second. Am I audible now? Am I audible now? Am I audible now?
Now it's fine, sir. Thank you.
Am I audible now? Hello? Yeah. Thank you so much. It's great pleasure to be a part of the KEM Shah Dental College CDE program organized by the Department of Periodontics. And as Madam rightly suggested, radiographs have become an integral part of our day-to-day practice, more than I would say, especially in cases of implantology and dynamic navigation is just not possible if we do not have the basic set of DICOM files, which become the data. We all know data is the king today, and that's how the next 45 minutes will be 45 minutes to 1 hour will be going ahead and talking about how this dynamic navigation helps us in achieving better results and getting the final outcome more predictable. Okay. So to start with, the journey of navigation actually started way back in 2015 when I came across an article which kind of compared the C-arm technology that is used in today's orthopedic surgeries, and they wanted to replicate something similar in dentistry. So imagine how great it would be if you could, in real time, see where our drill is going. So that means if you're placing an implant in the upper first molar on the right side, and there's a sinus at 7 millimeters, so assuming and doing it was the earlier technology. Seeing it and doing it at the same time in real time is what is the future. And that's what I'm going to talk to you about. So the whole concept of dynamic navigation comes from the possibility that X-rays, especially the CBCTs, the DICOM images that we get, it's converted into 3D visualization of the jaw and of the anatomy of the jaw, and then incorporated into the software such that every drill that is calibrated is seen real time. Okay. So as they say, eye sees what the mind knows. So we need to know now that how come these radiographic techniques, especially I'm going to emphasize more and more on the CBCT and in specific the DICOM images that we get in CBCT, how does it plan in computer-aided implantology? So as I said, I would say radiography is the third eye in implantology, and dynamic navigation system works precisely and in perfect coordination only and only when we have the right set of diagnostic DICOM images with us. So the whole world is moving from virtual to reality. In fact, when we have this 3D printed guides, when we have those bone guides, so everything is planned virtually and then replicated in the reality, in the intraoral cavity. Digital revolution is changing the world around us. So you have a look in last decade, so much of digital dentistry has come into practice that it has come for us to think, is this the future or there's something more that's going to happen? I strongly believe that our basic dental skills are the most important aspects for any technology to be adopted in our practice. See, if we are not well versed with the science of implantology, then all this additional armamentarium, let it be dynamic navigation system or static guides, are of no use if we really do not understand what this CBCT or CAD/CAM, 3D printing or intraoral scanners can be of use to us. Why we are moving towards digital is, one, it's faster, it's more predictable, it's cost effective compared to the earlier technologies where there was not so much of accuracy with that. And more importantly, it's much easier and user friendly. Now, before we go into the radiological aspect of navigation and how does radiographs help in navigation technology, especially with the DICOM images, let me get back to you to the history of how this navigation actually came into picture. So it was the year 1994 that in the neurosurgical sciences, they invented a armamentarium known as the weaving wand. And this was the first commercially successful CT-based navigation unit used in guided neurosurgery. And we all know neurosurgery is that part of science wherein a millimeter here and there and you goof up, you end up causing collateral damage. And that's why the precision comes from the neurosurgical aspect. So what changed as far as the dynamic navigation is concerned? How did it come into dentistry? Is only and only after the year 2003 when the Micron tracker, which is the first vision-based optical tracking system. So what it does basically is it uses a stereoscopic vision in real time to detect and track specially marked objects. So what it does is these are two set of cameras and they detect this black and white checkerboard markers which are attached to your handpiece or the patient wears on the head if you're doing a maxillary arch, which I'll show you in the coming videos. And then there's a logarithm that attaches these three and forms a tripod. So make it more simple. So this is how a dynamic navigation system unit looks like. The one I have is a Navident. There are many others in the market. And this comes with a portable cart system. You can carry from one chair to your other chair. If you have a multi-chair practice, you can carry from one center to other center, but we need to do a calibration every time the machine is moved with a lot of vibrations. So it has got a camera, it has a laptop, it has a boom arm, and the laptop is loaded with the Navident software. So what is this Navident? or what is this dynamic navigation? So we all are very familiar with the Ola and Uber app. So you sitting in Baroda, if you have to travel from KM Shah Dental College to the Baroda city, you open up your app. The moment you open up your app, the satellites on the top recognize your telephone, your mobile phone as one source. The other source is of the Uber driver who also has his app open, and these two are connected by the satellites. Now what happens is you open up and you decide where you have to go. So from KM Shah Dental College, you have to go to Baroda railway station. So you say destination from and to. So your map is ready. So the Uber guy knows or the Ola guy knows where you are, and you know from where is he coming. So this coordination happens because of the presence of satellites which are there up in the space, which are coordinating these events. So in navigation also, so we have the software which is connected to the satellites on the top. So this software, because of its stereoscopic vision, can detect this black and white checkerboard markers that you see on the screen here, which are attached to your handpiece, and these are attached to any handpiece. I have done endodontics with this, I've done orthodontic surgeries with this, I have done piezo surgeries with this, we have done normal routine implant surgeries. So all you need to do is attach these black and white checkerboard markers to a handpiece, and the other part of the device, the armamentarium, is attached to the patient's jaw, depending on which jaw you're doing. And then you have your planning, which is a very easy software. So you import your DICOM images. So what is the importance of radiology here? Or I would say this is just not possible if you do not have the DICOM images. So getting the right precise DICOM images, unstitched format, loaded onto the software helps us in planning how the implant has to be placed. And then the whole process starts. So how's this going to work? I'm just going to give you a brief idea of the core functionality of dynamic navigation system. So you have the data. The data is definitely the first is the DICOM images. You can also have added up with intraoral scanners. So you can merge both the sections and you can create 3D soft and hard tissue. So then you have this model of the anatomy of the patient. You plan in the software. You register the patient's jaw with the stereoscopic cameras, and then every instrument that goes into the patient's mouth, including the handpiece, is calibrated. And you can see in real time where your drill is going. If time permits, I will show you one or two endodontic cases, and you will be able to appreciate that how beautifully this navigation system can be adopted for calcified cases, for periapical surgery cases, for instrument retrieval. Okay, so we have to understand why we are talking about dynamic navigation, why we are talking so much about digital dentistry. To be more accurate and more precise and less invasive is today's way of going ahead in clinical practice. And more complex cases can be tackled with increased confidence and certainty. Very honestly, it's been more than is indirect sinus lift, and I've done this only and only with the help of navigation, because I know exactly where I'm at the floor of the sinus, and that I do not perforate it, and I can lift it with my Densa burrs. And the good part is you don't need physical guides. These are a little cumbersome, expensive. The third party makes it. And if you have to do some changes in the patient at the time of surgery, then these guides cannot be of use to us. Another important thing I believe is technology is there to help you strengthen your practice. But let me remind you again, it is your skill, it is your knowledge about basic dentistry that's the key. Okay. As I was talking to about computer-aided implantology, we have got two approaches today. That is the static and dynamic. Static is the one which we call it as guided implantology, or today almost every other implant company in the world has a guided kit, and they have tie-up with the laboratories which help you making a customized guide. But in this case also, the basic data that is required is a CBCT DICOM images of the patient. So you procure the data, you put it in the software, you plan your implant placement, You decide the path of insertion of your implant, and accordingly you get a guide printed, and that guide is then placed on the in the area of interest of the jaw and secured, and then the drilling happens. So here your guide is your plan, and that is, I feel, is one of the biggest disadvantage of static guides, because in case if I have to change anything here, it's just not possible, especially in case of immediate extraction, where sometimes the buccal plate cannot be saved while extracting, or there is a change in the bone pattern there and you want to move ahead to some other anatomical site in the same jaw. The guide is of no use to us because this is a fixed guide. You cannot do any changes in this. That's where dynamic navigation is different. To tell you briefly, we have some pilot guides wherein only the pilot drill is used to check for the first reference point, but we cannot have any verification in this. The tooth supported guides are very stable, but they have very restricted access. Visibility is very much hampered, and most often irrigation does not reach to the core of your osteotome preparation. Mucosa supported guides are good, but they are not ideal for immediate cases, and stabilization is a big factor wherein most of the times these guides cannot be secured firmly in the patient's mouth. Bone supported guides, which is another upgraded version of this, which is like you decide how much of bone needs to be taken out, you open up the flap, you place this guide. These also are great.
Excuse me, sir.
Yes, ma'am.
We can't see your screen.
From the beginning or just now?
From the beginning, I suppose.
Really? Oh my
Yeah,
God.
we thought you will share soon, but then.
No, I have shared 1 minute, ma'am. Just let me just go back. I'm so sorry. I did screen sharing. Let me just go. Thank you for this. I will just make a note. Share screen. Oh my God, ma'am. Now is it coming? Ma'am? Monali, ma'am?
Sir, we can see it.
Okay, now let's get to the first thing that I wanted to talk to you. Can I go back briefly few slides, ma'am, if it's okay with all of you?
Yes, sir. Yes, sir.
I'm so sorry. Okay. Is the screen visible now? Ma'am, is the screen visible?
Yes, sir. Yes, sir.
Okay. I was talking about this weaving wand, which was the first commercially successful CT-based navigation unit, which is used in the guided neurosurgery. And we all know neurosurgery is such a precise science, wherein 1 millimeter here and there, you end up causing a lot of damage, collateral damage to the adjacent areas, and that can be fatal for patients. So from the year 1994 onwards, there has been a lot of upgradation in this, but 90 to 95% of surgeries that are happening in neurosurgery across the world use this CT-based navigation unit, and that's how they get precision. So, 1 second. Why is my screen not moving down? Give me a minute. Yeah. So it was in the year 2003 that this micron tracker was invented. And what is this? This is basically cameras which use this stereoscopic vision in real time. So basically, it's an optical tracking system. It tracks few objects of the surgical site, and that's how it guides. So what are these few objects? These are these black and white checkerboard markers, which I'll show in the next slide. So this is how my Navident looks. It has a laptop which has an inbuilt software, So since it's a cart system, it can be moved from one operator to the other operator. It has a camera box there, and this camera box is the key along with the software. So this camera box, if you see, it has got two stereoscopic cameras, and this detects the black and white checkerboard markers. Now, to make it more simple for the audience there, I did speak about this, but let me show you the slide. How does this navigation works? Navigation basically works just as simple as your Ola or Uber app or GPRS. So, you know, from Kemsha Dental College, if you have to go to Baroda railway station, you open up your app of an Uber, and the Uber guy in the nearby vicinity who has his app open knows from where he has to pick you up, and you know from where he is coming. So both of you know your locations and you can track. At the same time, both of you know the destination that you have to go to. So that's how in dentistry it works. So we have this black and white checkerboard markers. These are special armamentarium which can be attached to any handpiece. So as I mentioned to you, I did orthognathic surgeries, I did periapical surgeries, endodontic cases, implant cases. So all I need is this black and white checkerboard markers which are attached to your handpiece. And then another black and white checkerboard marker is attached as a jaw tag. And then the triad is complete. I'll show you in the coming slides so then you have a clear idea. So this is basically in brief to understand the core functionality of a dynamic navigation system. So the basic ingredient or the basic need for you to proceed before you actually plan anything is the DICOM images. So that's the importance of radiology in today's dentistry. Especially, we are talking about CBCT images. The DICOM images that are procured from the patient, from the source. That means if you have your own CBCT machine in your department or in your clinic, or you're getting it from a third party, make sure those DICOM images are loaded. If you have an intraoral scanner, you can merge both of these. You can have the both hard and soft tissue anatomy with you. Plan it out. It's much easier to plan these cases. The software is very easy to understand. You plan where your implant has to go. And the best part is the planning is prosthetically driven. So you pick up a crown, place a crown, pick up an implant, place an implant, check where the implant angulation is, how is the access opening coming if you're planning for a screw routine. You can also select the abutment at the same point of time. Once this is done, you register that jaw with the Navident software. What is registration? Basically, you select 4 fixed anatomical points in the mouth. So if you're doing a maxillary arch, and if it's a partial edentulous, you can select 4 teeth. They can be a fixed partial denture also and not a removable partial denture. They can be an earlier implant. They can be a natural tooth that is not mobile. Select those 4 anatomical areas, register that jaw to the software, and then calibrate your handpiece, calibrate your drills, and go ahead and you can in real time see where your drill is going. Okay, but the question comes, why are we talking about dynamic navigation when the world across 80% to 90% of implantologists are still doing the conventional technique? That is, they have a look at the DICOM images before the patient is seated onto the chair. They have a mental mapping of how their implant has to go. They call the patient in, open up the flap, place an implant, or during the pilot drills, they take an X-ray and they make sure that the implant, but they are not visualizing anything in the real time. This all is assumptions. And many times implant failures happen when this execution from visualizing on the films or on the email and incorporating into the patient's mouth is where the major error happens. And that is where this dynamic navigation plays the biggest role. So it's more precise, it's less invasive. As a periodontist, to be very honest, it's been 5 years I have this machine, 5 to 6 years. And most of my implants that I do in my practice these days are flapless, but it doesn't mean that I don't do flap procedures for my implant or open flap. So whenever I need a graft membrane or I need to do some modifications in the anatomy there, I definitely open up the flap and do it. More importantly, in more complex cases, this can be tackled with increased confidence and certainty. no guides are needed. And that's so good, because the guides, 3D printed guides, if you have your own system, it's okay. But most of the laboratories, most of the clinicians in our country and abroad outsource it to a third party in the laboratory. And then that's where the precision is lost, or many times because of the poor fit of the prosthesis of the guides, we do not get that exceptionally great precision in such cases. And I firmly believe that technology is there to strengthen your practice, but your basic dental skill as a dental surgeon is the key to it. So my friends, all of you listening to this webinar, understand we are talking about digital dentistry, we are talking about navigation, we are talking about CBCT, but if your basic dental skills are incompetent, then these technologies are of no help to you. Computer-aided implantology has two different approaches. As I mentioned to you, the static and dynamic. In static, you have the DICOM images, you plan it out where your implant has to come, and then you send it to a laboratory to get a 3D printed stereolithographic print guide, which you place it in the patient's mouth like this. You have the pilot guides. The guide is your plan. You really cannot do much of changes here. Suppose I want to place one more implant in the upper second molar area, this guide of no use to me, because my planning is only till the first molar area. So in that case, dynamic navigation is really important. Then we have these different types of guides, the static guide, the pilot guide. Then we have the tooth supported guide. They are very good, they fit well, but there's a lot of restriction of irrigation there. Visibility is hampered, and the access to the osteotome site is not very good. Then you have this mucosa supported guide. They're also good. I've used few of them. The only difficulty I found with them was many times to stabilize this is really difficult. And it's just not ideal for immediate implant cases. These are very good, but then you need an additional surgery. And in spite of an additional surgery, you're still not sure of the fit of the guide on these cases. So we are talking about dynamic navigation. And what does dynamic navigation does? It tracks the position of the drill with the pre-acquired CT scan kept in registration. And that's how the correlation happens. So this is how the software looks like. You can see a 3D view. You can see a panoramic view. You can see a cross-sectional view. You can see a tangential view. And you can see an axial view. So now, how much of great importance is given to getting the perfect DICOM images can be visualized from these one software that is planned. So you can see a panoramic, you can see a tangential, you can see a cross-sectional, and you can see an axial image. And let me tell you, friends, this is one-time DICOM images that you have, which you have put it in the software. The rest of the time is the stereoscopic cameras which are working and not the radiographs. So you got my point? So the basic data is the radiograph image that you need to have. And then it's all the software and your registration that comes into picture. So all these images that you see in the real time is because the stereoscopic cameras, and there is no radiation involved in this. And then you have these settings wherein you pick up a crown, you pick up an implant, you pick up the abutment, and you go ahead and do it. Why I'm going in little fast is because I want to show you clinical videos where I'll show you every aspect of this. We all know the accurate reporting of the exact position of the drilling burr, it minimizes the potential risk and damage to critical anatomical structures. And this is so very true as far as my indirect sinus lifts are concerned. So we are into a process of publication. It's already been accepted in an international journal. We have done 84 indirect sinus lift cases with the host bone being just 5 millimeters. And with the use of densa burrs and navigation, we have achieved in 82 cases, no perforation, and we have been able to do a indirect sinus lift. In 2 patients, might be, I could say it as operator error, because sometimes if you apply too much of force, even with the densa, you tend to perforate the membrane, the Shinrin membrane there at the sinus area. So safety is amazing with this dynamic navigation. This was one of the first articles that I wrote in an CBCT magazine, which is again by Computer Aided Implantology Institute across the world, which has this there as a their in-house journal. And here we spoke about how CBCT plays an important role in dynamic navigation. So then when we are talking about dynamic navigation, let me take you through the steps so that our understanding of the clinical cases and the video that I'm going to show you makes it much easier for you. So what is this TAP? TAP is trace and place. What does it mean? Is you trace patients' fixed structures in the mouth to the software, and then you start placing the implant in the patient's mouth. So first and foremost thing that you do is you have to have a patient's recent CBCT scan, DICOM images, recent, taken within the last 3 months. And especially if a patient has undergone orthodontic therapy in last 3 months or any kind of fixed prosthetic therapy, then it's better to repeat the scan a day prior or the day of your implant placement. So once your DICOM data is ready, then you do this planning, which I'll show it to you. So you select 4 anatomical areas of the jaw that you're working on. So if I'm doing in a maxillary arch and I have to place an implant in a upper right first molar, so then I'll select the upper second molar, the canine, the lateral incisor, and the other side canine as 4 reference points, which are then traced and they become as a fixed reference point. So what is that fixed reference point? Let me give you a very simple example. You book an Uber, but if you forget your phone in the Department of Perio at KM Shah and you're waiting at the main gate of KM Shah Dental College, will the Uber guy make out that you are there? No, he will still think that you are somewhere in the department. So what's going to happen then? That mobile is your fixed reference point. And that is what is to be done here in navigation. You need to have 4 anatomical areas which become a fixed reference point. Based on that, every drill that goes in the patient's mouth is calibrated and the reference is then seen on the screen in the real time. Then you make the patient wear a head tracker. How does this head tracker help? Is it has those black and white checkerboard markers and they are captured by the stereoscopic cameras. And then we do the accuracy check. We calibrate the handpiece and the tip and we go ahead and do it. Now let's talk about what is our main topic today is the role of radiographs in implantology and how are we achieving precision and predictable dentistry based on these images. So the first question I have is it a good idea to have a preoperative baseline x-rays? Definitely yes, because 3D imaging is the key for all of us to understand how different the image can be interpreted from a 2D to 3D. Okay, I have few slides coming up next to show you why 3D is important and how does it help us in planning your implant procedure along with the prosthesis, and most importantly, how can we achieve this with more precision in complex cases. So is CBCT accurate? Absolutely yes, because the whole idea is in CBCT, what you get is the isotropic images. What you get in CT scan is anisotropic. What is isotropic? Isotropic is basically, it's that physical property of an object which has the same value when measured in different directions. That is why CBCT is more precise in dentistry compared to a normal CT scan. So what are we talking here is this CBCT image that we get is isotropic, means it has the same value whenever we measure from any of the directions. Okay, we have the least variation whenever we have a CBCT images. So what do we see on a CBCT image when we have to plan for an implant is we see an axial section, we see a sagittal section, and we see a cross section. And these 3 images form the backbone of how this model is 3D modeled and how is the visualization of your implant seen. Now, the next question that comes to mind is, now we have spoken so much about CBCT, DICOM, that is the baseline. Until we do not have the CBCT or until we do not have this DICOM images, we really can't do navigation. So is that the best resolution dental imaging? As of now, today, one thing is for sure, that more the pixel, sharper is the image, and that overall affects the sharpness of the image. and the measurement is much better with CBCT compared to our naked eye. So human eye, when compared with the CBCT, CBCT is at least 5 times better as far as the interpretation is concerned. And when we talk about RVGs and other phosphor sensors, it's far, far ahead as far as the CBCT images are concerned. So my friends, as of now, I can say that CBCT scan done with the proper settings and the proper protocols of how the patient also should be standing and how the image has to be procured still gives us the best resolution as far as dental imaging is concerned today. I don't see in the near future a lot of change happening in this. Might be a software can get upgraded, but the acquisition of the DICOM images will still be the key of how do we go about as far as navigation is concerned. Now, a lot of times when we take a CBCT or when we refer a patient for a CBCT scan, we also have to see what FOV are we looking. FOV is field of volume. So what is the area of interest for you to place an implant? Suppose it's a single jaw and you want to place only a lower missing molar, then you can have a FOV of 5x6 or 5x8. That's more than enough. So this is used for endodontics or mainly for single implant. But whenever you have to do a upper and lower jaw, few implants, upper 3-4 implants, lower 3-4 implants, then it's always better to have a FOV of 8x8. But in case if you're planning for a major sinus lifts or major major pterygoid implants with upper and lower planning that has to be done, then I would say it's always better to have 11x10 field of view, and that will give a complete view of the dentition along with the airways. And how that's helpful is because that helps us in getting the precision as far as the imaging is concerned. So all this imaging that we are talking about, which forms the key for our planning and execution, depends on the DICOM images. So if the patient is not made to stand properly in the CT scan, CBCT when they're taking, and the patient's neck is tilted, or if the midline is shifted, or for that matter, if the apparatus, the CBCT apparatus touches the patient's shoulder while moving and the patient moves, then whatever images you get will give you a false positive image whenever you plan that out, and that's not what we are looking at. So friends, our data should also be from a standardized source with the best apparatus that's available, and that will help us in achieving far better clinical outcome. And these are a few of my slides that I've taken from my friend. So how does this tomographic images helps us is like the slices of an apple. So we basically we get this DICOM images, and then we club all of this to look how an apple looks like. In this case, like the slices are the DICOM images, and then you construct them in a 3D pattern in a software, and that's how you go ahead and look it. Is this thing seen on your screen also? The meeting is being recorded. Should I leave it like that, madam? Hello?
Yes, sir.
This meeting is being recorded. Is this screen seen on your screen also, or it's only seen on mine?
No, on the screen also.
Screen also. How do we get this out?
You don't want to share your screen, sir?
No, share. I want to share. This meeting is being recorded by the host. Is that seen on your screen?
No. It's only on yours.
Okay, then it's only on mine. Perfect. So these are the images that we have here to tell us how important it is for a scan. So you have the sagittal section here, which shows the fracture of the tooth. We have the cross-section images, and we have this image. Now see, now the cross-section image has shown how the tooth has split at 2 different levels, and that will give us an assessment of how difficult the extraction and immediate implant would be. Now, if you look only at the sagittal section, which looks like an IOPA view, we assume that it's just a horizontal crack and not like a step crack. Now, this kind of imaging visualization is only and only possible when we have a 3D visualization of that area. And when can we have the 3D visualization? When we have the DICOM images, which are then constructed and seen in different sections. Or an image like this. Now let's look at different sections of this. So we have a fractured molar, which is not so much visible on a sagittal section, which is the IOPA view. And then when you see through the axial sections, you actually see where the fracture line has progressed to. Now look at this periapical. We feel, oh, there's a periapical and we might have a buccal perforation. But in reality, when we go through the CBCT images, we realize that the infection is more on the palatal aspect. So this will change your treatment plan. Why I'm showing you these few images is to tell you that every case that comes to us for an implant procedure, I believe we should make it mandatory to have a CBCT image of that area of interest for us to understand the anatomy well, and also of the adjacent areas to check how are the teeth adjacent to the implants, if there are present any, and whether they have any infection or not. Okay. Few more images of a cracked distal root. In this case, this patient walked into our practice. Endo was done recently. Patient came with a lot of pain. The endodontist took IOPAs. We couldn't find anything. And then when we got a CT scan done at my practice, we realized we saw the crack, and this visualization helped us in telling the patient that in spite of the root canal, in spite of a good root canal, this tooth could not be saved because it has developed a crack, and this needs to be taken out, and an immediate implant can be planned in that situation. Okay. Few more images to show you how a crack line can be visualized and how this can help us in planning our prosthesis or planning our implant treatment along with prosthesis much easier. So now let's get back to our navigation part. Now that I have told you what the importance of what CBCT is, let's see how we can incorporate this and achieve much better. So this is what you see is a tracer tool. So this also has got black and white checkerboard markers, and the tip has a rounded end, ball end, which has to be traced on the teeth, which I'll show in the subsequent video. So this is a tracer tool. So this is important because everything that goes into the patient's mouth is calibrated here. So this is a calibrated tool. So you have different markings here, 1, 2, 3, 4, 5. So basically 1 is to calibrate your handpiece, 3 is to calibrate your piezo surgery, and the dimple that you see there is to calibrate in the center that you see there is to calibrate your every tip. Okay, this is how the calibration happens. And then this is how I'm calibrating my tracer tool. So this is a cool head tag you make the patient wear. There are 2 variants of this, and this is how you make the patient wear very comfortably. And this black and white checkerboard markers are then captured by the stereoscopic camera. So see here, so we make the patient wear this, and if it's a lower jaw, or the jaw tracker can also be used for maxillary arch, you use any resin adhesive and bond it temporarily with that tooth. So this black and white checkerboard markers are captured by the stereoscopic cameras to register our jaw. These are the different jaw tags that are available. Now I'm going in little speed so that I can give you more detailed explanation when we are doing the clinical cases and you have a clear idea of what this is. So this is an important slide, and I want you to understand how does this help. So you saw the 2 stereoscopic cameras on the Navident armamentarium, the machine. So the camera box has got 2 stereoscopic cameras, and they are detecting these black and white checkerboard markers all the time. That's how the calibration gets. That's how the triangulation is complete. Sorry, not calibration. The triangulation is complete, and that's how every drill that goes into the mouth can be visualized real time in the screen. So this is how we work. We have I'm calibrating the patient made to wear a headgear. I'm calibrating the handpiece, and I'm looking to the screen, and that's how we go ahead. Okay, so let's go through our first video. So this case, we did it way back in 2017, 18 Jan. And what we did was this in fact won me the best case presentation award at Rome at the first Navident meeting of the KOL speakers. So this is how we are tracing the teeth. So 4 teeth to 5 teeth is what we record. Record in the sense we calibrate, we trace. So what I'm doing, I'm making the patient wear the headgear, and in the patient's mouth with this DICOM images, I'm now going to calibrate, and everything is recorded. You see here, everything gets recorded. Everything gets recorded here. It's me here working. The patient is here. So I'm calibrating. She is made to wear a headgear here. See this? And this is my jaw tracker or my tracer tracker. And I'm running that instrument in contact with the tooth to get a score of 100. And every time we get a score of 100, we move on to the next tooth. So we get a score of 100 for all the teeth. And once we get it, the registration is complete. And now this is the planning that I've done. So you see this, the yellow outline is the planned position of the implant. This is the planned position of the crown. What I'm calibrating is my handpiece. So you see here, I'm calibrating my handpiece and I'm checking my drill. Where is the drill going in? And this is seen in real time. And let me tell you, friends, this is not any kind of radiation involved. This is basically your stereoscopic cameras, which are capturing the head tracker of the patient and the jaw tracker along with the handpiece that I'm using. So this is one thing I wanted to show you, that while starting with the procedure, I change the angulation of the implant. And this is just not possible whenever you have to do a case with static guides. So only with dynamic navigation, you are able to change this. So what I did, I kind of changed the angulation of the implant so that my screw axis comes more in the central fossa of the crown. So see this. So this concentric circle that you see on the upper left, on the lower left side of the screen, which I'll show it to you now, tells us about the position of my handpiece. So you look at the error. My error is less than 1 millimeter at any given point of time. It's going beyond that, and then slowly you will see the correction happens. And we went ahead. So it's less than 0.1. As soon as I enter more deep in, you'll see I'm going to correct that, because right now I'm in the soft tissue. So I'm using a punch. Now I've come to the pilot drill, and look at my error on the lower left segment here. It's less than 1 millimeter. I'm talking about millimeter. It's less than 1 millimeter. Look at my angulation error. It's less than 10 degrees. Most often, especially when I'm placing the implant in, it's going to be even more less. So we go ahead. Every drill we calibrate it. Here I'm using a Densa burr. So every time a drill is calibrated, it says verify it with the adjacent teeth. So you place it with the adjacent teeth and check if it's correct. So I'm keeping in the fossa of the premolar. Perfect. I can see that. Now see this. This is how my drill goes in. I get to know the amount of length that I need to go more in. So this is where you get to know the length. So it says go 9 millimeter more in, go more 8.8 millimeters. Look at the error pattern here, less than 0.5 millimeters now. Okay. And look at the angulation error. It's less than 10 degrees now. So this is how every drill goes in. I'm going through this to show you a few more videos wherein we have much more nice cases. And this is how it goes in. And we go ahead. We place the implants in. So in the end, if you see, my placement of the implant has been with sinus lift in both these cases. And we could go ahead and plan the prosthesis for the patient. Okay, let me go back one slide, please. Yeah. So this is a very interesting case, which I'm going to show you from start to finish, how we did the planning. And in this case, I'll explain in detail. So we took the patient DICOM images, put it in our software. This patient had a upper left 7 missing with very less bone. It was less than 6 millimeters of the host bone, and we wanted to do an implant here. So missing tooth number 27. Once the software is loaded, you mark the arc shape of the jaw. You draw the curve. So by drawing the curve, you pick up the area of interest, and then you know exactly where you have to place an implant. So what I did was I first picked up the crown. So you see this, I've not yet picked up the implant. From the software, I picked up the crown, placed the crown there, and then I decide what shape of implant I have to do. So I pick up an implant, place it there. So if I do a 4 by 10 millimeter implant, I'm going to perforate the sinus. So I decide to go ahead with a wider implant, 4.8 Straumann. But look at the sinus. Sinus is somewhere at around 6.5 to 7 millimeters. This is how I'm tracing in the patient's mouth. So I'm first tracing the tracer tip, and I'm going to calibrate or I'm going to trace his anatomical areas and get the score of 100 on 4 teeth. So here we are doing the upper left 7, that's the second molar. So once I calibrated all the 4 teeth, once I traced all the 4, see, I'm seeing the accuracy of my tip. So now I'm calibrating my handpiece. Once the handpiece is calibrated, this is how I use my initial punch. So we took the punch tissue punch out. Now the flapless site is ready. Now look at my implant position. So precisely I know where is my implant has to go in. Once we do a pilot drill, following the protocol of DENSA, we are 1 mm short of our floor of the sinus. Then we use the next drill, that also we go 1 mm short. And once we reach to the 3.0 diameter DENSA burr drill, that's when I'm going to lift the sinus up. Please have a look on the left side and you will see the position of my handpiece. You will see my angulation error. You will see my position of the drill that goes in, and it shows with the crown in place. So at any given point of time, I know my implant, this that I'm going to place in the patient's mouth, is going to be a prosthetic driven. And friends, we all know implantology is so much prosthetic driven that we need to keep in mind, we need to place an implant where the crown has to come or where the prosthesis has to come, and not where we find a lot of bone. So presence of bone is important, but the positioning of the implant in the perfect 3D position is the key for the long-term success of any implant prosthesis. So see this. So I'm just gone there, and in the subsequent drill, you will see me lifting the sinus up. Okay. So now in the next drill is where I'm going to lift the sinus. Now I've gone to the floor of the sinus. And this is maxillary second molar. What difficulty you find if you have a static guide is your drill cannot be placed because of the positioning of the guide. You have less intra arch space from maxillary to mandible. So once you place a guide and then you want to drill, it becomes, now I've lifted the sinus. So that comes in the red. So once you lift the sinus up, because my planning was only till this, so beyond that I'm lifting the sinus up. So you'll see the clinical picture of how the sinus looks intraorally when we do indirect sinus lift, which I'll show you in the same presentation now, in the same video now. So once we achieve the adequate lift of the sinus, we place bone there. Bone metal can be of your choice. I prefer no bone putty because that helps me lifting the sinus easily. Many times the coarse nature of other bone grafts can perforate the sinus if the sinus is thin. So we go ahead, we lift it up, So this is where you can see the sinus in the intraoral view, and that's where my no bone putty is being placed. So this is the Strawman 4.8 by 10 millimeter implant. We place the implant at the surgical site, subcrestal placement, healing abutment placed. Look at the sinus lift that we could achieve. Then we wait for 4 months. Now what happens beautifully in this case is the healing is good. We go ahead, make an digital impression, get a implant crown ready. Look at the position of my access hole, of my screw access hole. It's precisely in the place where it has to be. And then you see how much of sinus lift we could achieve. Earlier, which was around 5.35 to 6 millimeters of the sinus, we could achieve almost 10.14 millimeters. So another interesting case, a complex case of all-on-4 with the teeth present. The teeth had to be immediately extracted. Now, in this case, what I did was I took few of the teeth which were to be extracted later on. So once I traced the teeth, areas where my implant will be placed, I kept those, I took out those implants, I took out those tooth and placed implants. And you see the rest of the teeth, I kept it because I had to trace them. And another different implant system we placed. And this, if you look at it, see, this is how I'm able to see. So especially for all-on-4, this is like excellent. I have never ever perforated any lateral wall of the sinus since the time I've got dynamic navigation, and I've done more than 72 all-on-4 cases with dynamic navigation. And we have seen with every case, we are able to achieve good primary stability. Most importantly, we have been able to have utmost safety of the patient, as well as avoiding any major catastrophe, as well as such complex cases comes in. We go ahead, we do immediate implant prosthesis. There's another interesting case. So this patient walks to us from Australia. He says he wants to get this tooth done. In fact, he needs a full mouth rehab. But when we took this tooth out, this is how the picture was. Now, in this case, many times when we do guided static guides, we cannot achieve that kind of precision fit. So in this case, we could, you see this, I'm engaging the palatal bone completely, and I can see in the real time. So we went ahead, placed the implant in exactly in the 3D position. Then we use a bio-HHP abutment, but you see that I'm using a membrane and the graft. So implant in place, bio-HHP attachment, and a crown given immediately. And then we expect the patient to come back later and go ahead and get his other teeth treated. Another interesting case. So this is, I had done an implant with 6. I had advised the patient an implant with 7, but then he was on a transferable job. He got his 7 extracted, which was traumatized extraction. So what I did with navigation is I took the tuberosity of bone. So after the registration, you will see here, I'm taking the tuberosity of bone with the help of navigation. So the amount of graft that I need, that also I did it with navigation. So the autogenous bone graft that I needed, see here in this image, you see in the radiographic image, there's no bone on this aspect. So clinically, you will see me using the bone from the palatal aspect, which was in excess, or shifting it onto the mesial aspect. Okay. Which you'll see now. See this whole thing has been covered up with the host bone, and this is the 3 months post-op. You will see in the pre and post-op the difference in the anatomy. Can you see the depression, which we covered it very clearly with our autogenous bone graft, which I could do with navigation. Now look at the grossly decayed 1/6. So again, we took this tooth out, automatically split it with the Zerka burrs. We had good interradicular bone between the roots, and we went ahead, we planned it out. We did a little sinus lift in this case. So that's the indirect sinus lift that you can see clinically. This is a BNB implant, which we use. We place the implant in place. See the torque, more than 45 Newton centimeter torque. We place the healing abutment, grafted that side, sutured it up, and we gave a prosthesis later on in this case. Another interesting case, a full mouth. That's how we went with navigation, pre-operative. All the teeth was extracted. We did a planning where the implant has to come. She already had existing 2 implants in her upper left side. So we thought of placing 4 more and joining all of this together. So in this case, we took an intraoral scan. So this is how I'm merging both the scans. So this is what I wanted to show, which I was talking to earlier. So if you have a DICOM image and then you have an intraoral scan image, you can merge both of this. So when you're doing clinically, you can actually see the soft tissue outline also. And that helped me in this case plan my angulated abutment. Now, how does this help us? See, this is where digital technology or digital dentistry is of a boon. So before I started this case, I send this STL file to the laboratory to tell them that this is what the angulation of the abutment has to be, and this is how my temporary prosthesis has to plan. So before I started, I had the temporary prosthesis in place. Okay, we registered her teeth. We got a score of 100 on all. See this, we calibrating, then we extracted the teeth. We calibrated the drill. Then every drill that's going in can be seen. Okay. This is the implant site 16. The green marking that you see is my position of my drill. The yellow marking that you see is the planned position, and the blue is the abutment. What kind of abutment, what kind of gingival height do I need? All that is pre-planned, pre-decided, shared with the laboratory. So everything is crystal clear. So implant site with 16, here implant site with 11. Then because we had a perforation on the 1-2 aspect, we switch over the implant to 2-1 site. We place the implants all 4 in, collagen membrane tucked, healing abutment placed. And there's another interesting case of Gadiali, which we did with all on 4. So this is her existing teeth. This is how we went ahead. This is how I took the teeth tracing. In this case, I took only 3 teeth because the rest of the were to be extracted. So we did an accuracy check. We placed 4 implants in the most desirable location. And then the best part is why I'm sharing these images with you is I could get this immediate 3D printed model. Why? Because I had the planned software, I had the planned case in mind. And how did I have this planning? Because I had the DICOM images and the intraoral scan, which helped me select the abutments and the prosthesis before we ventured into our surgical site. Once this is shared with the laboratory fabricates one. Once the patient walks into your practice, all you have to do it is you just go ahead and place this thing. And the case, I'll just show you the radiographs, how we went ahead with this. So all this is that was pre-op, this is post-op. This case where we did little osteotomy. Now, very interesting, if you look at it, the whole arch was the whole segment was supra-erupted. With the navigation, we could achieve stabilization of the bone levels and the implant placement. So this is how we gave her the prosthesis. And the interesting case, fully periodontally compromised. So in such situations, what I do is I first extract all the teeth, gave him complete dentures, told the patient to wait for precisely 2 to 3 months. Then we went ahead, planned the implants with the navigation. Here we used something known as micro implants to achieve that. And this is another interesting case, periodontally compromised, individual large photographs taken. This is how the teeth were. We planned all on 4, took all the teeth out. So went ahead. This is how I planned with that was the similar case that I showed you earlier. So I sent this to the laboratory with the intraoral scan to tell them this is how our patient's existing occlusion was. And they fabricated a temporary prosthesis. And this is the day when patient came for a follow-up after 15 days. We took them out for more corrections in the temporary prosthesis because now the gums have healed, they have shrunk. So there were a lot of spaces that the patient was not comfortable with. So that's one disadvantage when you give an immediate prosthesis. So patient came back after 15-20 days. In this case, I think she came to us after 3 weeks. So you see a little inflammation on the upper left distal implant. The rest of the implants look very nice, healthy. We went ahead, and this is the lower arch. This is pre-op. This is post-op. And this is how we gave the prosthesis. And these are, mind you, temporary prosthesis, which will be soon converting into final prosthesis. Monali ma'am, do you have another 5 minutes?
Yes,
do
sir.
I have another 5 minutes?
Yes, sir.
Okay, I just want to quickly show you how we use this CBCT images for navigation for removing a separated instrument. Okay. So this was the case. This was a patient who was 17-year-old undergoing orthodontic therapy. Because we had these CBCT DICOM images, we took it into our navigation study. This is how we are doing tracing the teeth. So you see this when I was talking to what is tracing. This is tracing 4 areas of the jaw, getting a score of 100 on each tooth. So now the patient's jaw is registered with the software. Once the registration is done, what we are doing next is we are then calibrating a BTR pen. I'm not sure of how many of you know, but people who do endodontics and people from the endodontic department know BTR pen is a device which is used, it has a loop in the front, which is used to hold an instrument, and you can pull that instrument out. So you'll see this in a more magnified view. So this is how it is seen. You'll see in a more magnified view, which I'll show it to you, how the loop looks like. So you see that it has a loop in the front. So we calibrated this also. So what I'm trying to emphasize is this navigation can be used in almost every field of dentistry, provided we know the science behind it and we have enough of our skills to understand how this has to be applied in those cases. So see this, the BTR pen is being taken in, and what we're doing is we are now from behind this, the knob is being rotated so that it holds the instrument. So you see this image here, it has held the instrument, and slowly look at here, the instrument is now slowly taken out. I'll quickly go through this. See this, the instrument, can you see the BTR pen has held the instrument and it's pulling out the instrument. See this? So nicely, this curved instrument could be taken out. A case of calcification, quickly we'll go through this. So this is how the patient came with calcification. We went ahead, we did the tracing, then we went ahead, calibrated the drill tip, and you see this, we could achieve, look at the access opening. Why I have shown you this video, and to emphasize that with dynamic navigation, with the radiographic images of the DICOM image that you have, you can be more precise and you can save more of the tooth structure. Now, if this was done at the naked eye, I'm sure there would be enough of destruction of the sound tooth structure, resulting in a lot of remaining root dentine would have been very, very thin. So we went ahead, we could achieve this. Then we use irrigation. We went ahead, did the gutta percha obturation. Sorry, I have not done this case. My friend Vivek did it, but I was there as the navigation expert to guide all this. The endodontic part was taken by him. So that's how the master cone, and that's how they went ahead and sealed it. So let's look at quickly one more case of navigation with episectomy. So we went ahead, this is pre-operative. So this is, I'm showing you, I'm using a piezo surgery. So you see this, these are the instruments. This is how I'm calibrating it. So you see this, I'm using my piezo surgery, incision given, flap raised, and precisely that much of window I could take it out. So this is my piezo. So this is exactly clinically. So I'm using my piezo surgery. I'm cutting that out, that much window of the bone. Once that is done, I went ahead, removed that part, only that part of bone was removed. We removed the root end part, degranulated it, or periapical curettage was done, periradicular. Root and cavity preparation was done with MTA, and the flap was closed. We did a case of dens invaginatus also. This is one of our publications that has come in the Indian Society of Periodontology last September, and which shows how we used navigation in case of a molar where the root was already amputated, and how we could achieve the precise 3D positioning of the implant in that area of missing 1/6, and how we could give the patient a prosthesis which was fabricated with a DICOM and the STL images that were shared with the laboratory. We recently did a expert panel consensus meeting. I was the only second Indian after Dr. Rahul to speak on that. There were 178 European dentists who we made a consensus report on how navigation helps us in achieving a better this thing. So dynamic computer-aided implantology can be done in one day. You don't need much of laboratory involved to print your 3D part or drill system. You don't need any sleeves. You can do when intraocclusal space is less. There's beautiful post outcome of the post outcome is great with less of edema. There's improved irrigation. There's reduced risk of bone damage due to overheat, and you have something known as ICOM. After have a
Hello. Excuse me, sir. Excuse me, sir. Hello.
hello.
Yes, sir.
Yeah, ma'am. Yeah, ma'am.
Sir, actually, the slide was fluctuating. That's
Which slide was fluctuating? The last one?
the last, yeah, sir. The conclusion.
I'll just play it again. Is it visible now?
Yes, sir. No slide.
Okay. Is it there now?
The slide is not visible, sir.
Even now?
Yes,
Just
sir.
check,
The screen is not visible.
1 minute. Let me just go.
Yes, sir. We can see it now.
Can you see now?
Yes, sir.
So what I was talking to you is this digital dentistry is a challenge, but the more important part is we need to kind of understand the equipment, the software applications, and then we need to do something what is known as safer and less invasive protocols, and that's how the future of dentists is looking at. Don't be surprised in next 6 months to a year we have something known as semi-robotic arm which will be attached to your operating arm, that will stop your drill from going from a position from your plant. Means it anyway, anytime you deviate from your plant position, the semi-robotic arm will stop your arm from progressing further, and that's how things are improving. And I believe that dynamic navigation is just a pilot in this. There's a lot of improvement that has to happen in stereoscopic cameras, the resolution of the screens, the image acquisition, the CBCT, and this will take us to a level of far accuracy in our dental procedures. Thank you once again to all of you for the patient listening. I'm sorry for the little technical glitches that happened from my side. And Monali ma'am and the whole team at Kemsha Dental College, thank you so much for the invitation. It's a pleasure to be a part of the perio department there for the CD program. Can I now close my, this is my contact details. If anybody has any questions, I'm open to the question answer session, or if they have any doubt later on, they can contact Monali ma'am or they can contact me, and I'd be very happy to share whatever I know. Thank you so very much.
Thank you, sir, for sharing your knowledge with us. It was a great session. I will now request all the delegates to ask any question if they have any.
Or at the end of the session also, after today's event also, at the end of the event also, they can ask me questions. I'm always there to help them out.
Yes, sir. Thank you so much, sir. Let us appreciate Dr. Sanjay Jain, sir, with an e-certificate for sharing his immense knowledge with us. Thank you, sir. It was great to have you here for the session.
Thank you so much. Thanks a lot. Thank you once again, everyone, for taking their time out. And I'm really sorry for the little technical glitches that happened. Initially, the screen wasn't being seen, and then sometime the audio was not audible. But I'm sure I could invoke a little bit of curiosity in your young minds of what this dynamic navigation can do. And as the theme of our today's topic is that radiographic interpretation in implantology, and how this DICOM images made it possible from going from analog to digital, and then from digital to real time, and that's how we are progressing in implantology in the near future. Thank you once again very, very much.
Thank you, sir.
Thank you.
We shall be taking a short break of 15 minutes, and we will resume our session at 12:05.
Thank you so very much.
Everyone is kindly requested to not log out of the meeting during the break. Thank you. Good afternoon, everyone. Now let us move on to our second session of the day by Dr. Mayur Kaushik Sir, Professor and Head of the Department of Periodontology, Subharti Dental College, Swami Vivekanand Subharti University, Meerut, on the topic Radiograph for Diagnosis, Treatment Plan and Follow-up in Implantology. Dr. Kaushik Sir is Professor and Head of the Department of Periodontology in Subharti Dental College, Swami Vivekanand Subharti University, Meerut. He completed his BDS from Manipal College of Dental Surgery and MDS in Periodontology from Government Dental College, Nagpur in 2005. He has received Dr. D.N. Kapoor Award. He has several national and international publications and has co-authored 9 books of his specialty. He has teaching experience of 17 years and is a well-known keynote speaker. He has been running his implant-based practice since 15 years at Kaushik's Dental Care, Meerut. He works as a course coordinator and mentor at Rochelle Implant Training Center at Lokpriya Super Speciality Hospital, Meerut. Now I request Sir to kindly begin his session.
Thanks a lot. Okay, I'll just try to share my screen first. Okay, please let me know if my screen is visible. So is my screen visible? Yes. Screen is visible. And now the PPT is also seen?
Not yet, sir.
Okay, the PPT is not visible.
Yes, sir.
Let me just give it a try once.
So visible now.
This is visible, huh?
Yes,
And
sir.
so now my slide sorter is visible. So is my first slide visible now?
Yes, sir. Not in the complete screen, sir.
Not in the complete screen. Okay. So it is like basically we are able to see this slide sorter otherwise?
So now it's visible. The first slide of your...
Okay. So now is the first slide visible? I think some lag is there in the internet connection at my end. So
now it's fine.
Now it is fine?
Yes, sir.
So are you able to see this thing screen, the first slide?
Yes, sir.
Is the slide changing? Just 1 second, I'll see. Is the slide changing?
No, sir.
Now is the second slide there?
Yes, sir. Yes, sir.
Okay, so I think some lag is there, but not an issue. Please bear with me as such, okay? Because I think some lag in the computer, this thing is there. So are you able to see the slide now?
Yes, sir.
So Jai Hind, everybody. I'll be starting with my presentation now. Do let me know, the host, please, at any point of time, if my PPT stalls or if you feel I am speaking and nothing is visible on the slide as such, please do let me know, okay?
Yes, sir.
I bring to you greetings from Swami Vivekanand Subharti University, Meerut. So is the slide of Swami Vivekanand Subharti University visible? Has the slide changed as such?
Yes, sir. Yes, sir.
Okay, thank you. Thank you. So with regard to our university, again, this is a huge university. It comes under Swami Vivekanand Subharti University. So till the time the audience settle down, I'll just take 2 minutes to introduce our university as such. So it goes by the motto of Swami Vivekanand, that is, arise, awake, and stop not until the goal is achieved. So this is our motto as such. And we basically work here in our university under 4 basic principles. We have Siksha. We are quite passionate about education. We are not driven by any companies, etc. We go by what is in the book as such. That is the first thing that we take care. Second is Seva. So we are totally in for any non-commercial activity. For example, those of you who might have seen our YouTube channel, etc. also, all the procedures like lingual frenectomy, types of physio dispensers, types of implant kits, etc. All these videos are for free, available on our YouTube channel, which goes by the name of Dr. Mayur Kaushik. So especially for the students who are beginners in implantology, they can just have a look and everything is available. Okay? Then, of course, we have Sanskar. We are quite particular with regard to ethics and culture. And finally, Rashtriyata. As you must have seen that we had begun our lecture by saying Jai Hind. So each and every presentation in our department begins with the Azad Hind Anthem. So these are the principles which are there of our university. And this is basically because our university is quite different from other private universities. Other private universities are run by many a times businessmen. Our people who initiated this university was our Dr. Atul Krishna sir, who is a general surgeon, Dr. Mukti Bhatnagar ma'am, late Dr. Mukti Bhatnagar ma'am, she was MD medicine, and the current CEO of the university basically is Dr. Shalya Raj, their daughter, who herself is an endodontist. So ours is a university of doctors run by doctors. And those of you who are not aware, as of now, when I say Swami Vivekanand Subharti University, I'm not just talking about a dental college or hospital. I'm basically talking about 19 different colleges. So our university contains as many as 19 different colleges which come under this university. So this is the university which I am representing here today. This was the first college of our university, which opened way back 26 years back in 1996, Subharti Dental College. So this dental college was the first. And then for the last 12 years, under the dynamic guidance of basically Dr. Nikhil Srivastav sir, he happens to be our principal, our college has been reaching new heights. I am the head of the Department of Pedontology and Implantology in this department. And whatever I am today, for the last 18 years, I've been working in this university. It is because I had a godly figure as a guide during my post-graduation, Dr. R.K. Eltivar sir. My post-graduation I had finished in the year 2005, April, from Government Dental College and Hospital, Nagpur, under the guidance of Dr. Eltivar sir. When it comes to implants, the first implant I had placed was in 2002. So now 22 is ending. So it has been a little over 20 years when I have been placing implants. And around 8 years back, 8 to 9 years back, we had started our own academy of teaching implants, Rochelle Implant Training Center, where we teach everybody how to place implants ethically. This is one thing which I always emphasize. Do not experiment. Do not experiment in your practice. Keep learning and earning separate. There's no room for bravery as such in your practice. So Rochelle basically is part of Lokpriya Hospital, which comes under Subharti group of institutions. This is the biggest hospital in Meerut. So this is in the heart of the city. It is not that I'm representing just the college. Dr. Rohit is the director of the hospital of our academy. He's an endodontist. And along with me, I always believe in an interdisciplinary approach. This is Sumit Makkad. He is a professor in Prosto. And with me is Prajesh Dubey. He is a professor basically in oral surgery. So together we teach people how to place safe implants, how to ensure that your implants don't fail as such. Rochelle basically is short for Dr. Rohit and Dr. Shalya, his wife. So Dr. Rohit, the director of the hospital, and Dr. Shalya, Swami Vivekanand Subharti University's CEO. So once we established the university, it is not that I practice only here. Okay. Last 18 years back, I had joined my father in his practice, Kaushik's Dental Care. So this is a small setup at home. I'm a small town practitioner. Okay. So I'll be teaching you basic things only. And this is my wife, Dr. Nupur. She is a professor in the Department of Pedodontics. My papa, who is a general dentist, 72 pass out GDC Amritsar. And we have a small setup in which touch wood we are doing pretty well with regard to implants especially. And this is our small world, our 11-year-old daughter Adya. So this was about me, just 2-3 minutes, sorry, I took till the time I felt my PPT and my net connection would stabilize. So I hope the slides are changing. The hosts, is it fine? The hosts are still here?
Yes, sir, it is.
As I was attending Sanjay sir's lecture, and initially I was thinking the same thing, that maybe sir is trying to speak everything extempore. And then I realized it was a glitch, that the PPT was not working that time. So I hope my PPT is visible. So I come to the main part of the PPT. Huge thank you to Monali ma'am. Thanks a lot, ma'am, for considering me worthy of this honor to speak on this platform. A small time practitioner like me with Sanjay sir, such a renowned implantologist. And ultimately, as I had discussed with ma'am, that my lecture would be quite basic as such. And then sir would be presenting his advanced lecture on implantology. But because of some time constraints of sir, I think they were interchanged. So now I am presenting the basic lecture later on, and sir has already presented the advanced lecture. So I'll be speaking basically on the role of CBCT as well as chairside imaging when it comes to implantology. So this is what I'll be covering in my topic as such. Okay. So when we talk about implantology, I think many students must be there in our delegates who are attending this webinar. Students who have just now started with implants and who definitely know that implants will be there in their practice for sure. So what is implantology basically? So implantology, many a times we are obsessed with the prosthetic component, the crown part. But one thing which we have to remember is that the prosthetic component, the implant, the crown, that comes much later. First and foremost, this prosthetic component, the suprastructure, has to rest on this structure, the implant. And this implant has to survive by it being placed surgically in living bone and soft tissue. So please understand, if the base is weak, the superstructure is bound to fail. So the world over accepted definition of implantology is it is prosthetic driven surgical treatment modality. So please understand, if you are not a good dental surgeon, if you're not practicing dental surgeries routinely, no matter how good your imaging lab, your radiologist, or anybody is, that person cannot substitute for your basic surgical skills. So when I talk about basic surgical skills, it is all about I, R, and S. So incision, reflection, and suturing. So all of you please understand, it is an age of commercialization. All these companies have come in. They have told us they'll give us a stent, a CBCT guided stent, and blindly anybody can place implants. Flapless implants. No, I won't be covering up the dissertations, the 14 researches of implants done under me. But all I can tell you straight away is, please understand, there is no substitute to basic dental surgical skills. Okay, so this is the first thing that you're supposed to understand. Otherwise, we'll end up getting cases like these. So please understand one thing. We as practitioners in India, be it a small town practitioner like me, or be it a practitioner in some big city, we require dental implants. So why do we require implants in our practice? That is because, firstly, monetary gain. No other modality in our practice offers even half, or let's say 1/4 the amount of money which implants offer. So basically, implants are the money makers. They are bread earners mainly in practice today. If you want to be successful, implants have to be part and parcel of your practice. The second thing is, of course, status symbol. So gone are the days when people used to flaunt, I am an orthodontist, I am an endodontist, etc. Now, straight away, before they open up the clinic, the first thing they want to write in front of their name is, I am an implantologist. Okay, so that implantologist word, or dental care and implant center, is the thing that they want to write first. So this is a fact. So please understand, without implants, neither money is there nor fame is there, and success is all but fame and money. Okay, so this is one thing that we have to keep in mind. But at the same time, not every case of implant, not every case is a case of implant. No matter how good the CBCT report is, no matter how good your stent has come from the lab, few cases you cannot place implant. So please understand, the first is, of course, space for a tooth is not there. This is the first thing that you are supposed to evaluate. Horizontal and vertical dimension needs to be present for a tooth. If that space is missing, no matter how good bone is there, you won't be able to do a damn thing. That's the first thing. The second thing, which again, a basic thing which many students are not able to see beforehand, is accessibility. If decreased mouth opening is there, You're not able to place your physio dispenser handpiece vertically in that area where you are planning your osteotomy. That is where that is not a case for implants. And final thing is, of course, if available bone is less. Please understand, regeneration is not something which is quite predictable, which is quite fast. So again, if bone is less, you have to make the patient understand that chances of failure might be there. So how do we evaluate this bone? How do we go about evaluating a case of implant? So straight away, a patient has come to you. What are we supposed to see? Firstly, whether mesiodistal distance appears to be fine enough for placement of an implant or not. After that, we are supposed to make the patient occlude and see whether interocclusal ample distance is there for placement of a tooth or not. This is where your imaging has to begin. Clinical examination first, then the imaging part has to start. Okay, so nothing is a replacement of your eyes. This is one thing which I'll emphasize again and again in the lecture. Nothing can replace you. As of now, no robotics, etc. would be coming. At least I expect not in my lifetime. But the point remains the same. You have to examine first. But the issue is the bone. Once you have evaluated it prosthetically that a tooth can be placed, how to evaluate bone? So again, with regard to diagnosis, please start, remember, basics first, then the high funda stuff. So straight away, once you feel tooth has to be placed, the next thing which you are supposed to do is not refer the patient for a CBCT straight away. This is the first thing. You have to start with the basics. You have to get an OPG first. So suppose the report of an OPG comes something like this, meaning with regard to the canal also and with regard to the sinus also, hardly any bone is available. Then it is a backup. Please remember, no advancement in technology can replace biology. That is a basic thing. So if height of bone is not there, there is nothing much that a CBCT will help. In this case, implant cannot be placed. End of story. First thing. The second thing that you are supposed to remember is if the report comes like this, ample bone is available, but this is a two-dimensional image. You require a three-dimensional image for the width also. So this is where a CBCT comes into the picture. So this is the thing where you'll be advising a CBCT. So first advise an OPG. If the OPG report is good, then go ahead with a CBCT. Okay. So, but the issue is the same. CBCT, my goodness, straight away. I find it very difficult to convince my friends in nearby small cities of Muzaffarnagar, Modinagar, etc. They have two main misconceptions about CBCT. First is the cost factor. My goodness, how to convince the patient to pay extra for the CBCT. And the second is the radiation exposure. So with regard to the cost factor, I'll cover it up in the subsequent slides. But the first misconception that you have to understand, which has to be cleared, is with regard to the radiation exposure. We feel CBCT has a lot of radiation exposure. So here I would straight away like to quote things from MISH, the so-called standard textbook of implantology. So in this MISH, it is clearly said that the radiation dosage of CBCT of a small area is 40 to 60 times lesser than that of conventional CT. So this is the first thing which you have to remember. Straight away we think CBCT means CT, ample radiation exposure, 40 to 60 times lesser. But then again, as a dental doctor, we don't advise CT much. So what we feel is we are not able to apprehend it straight away. So please understand, I'll tell you from a dentist point of view, dental surgeon point of view. The radiation exposure in CBCT of a small area is actually 1/4 to that of a conventional OPG. So how many of us think twice about radiation exposure before advising an OPG to a patient? We don't. It is 1/4 to that of an OPG. CBCT exposure of a single area. So please, as far as possible, you have to incorporate CBCT in your practice. This is a message. So let us start with a case, a simple, straightforward case. This patient had come to my clinic. It has been, I think, 7-8 years now. So she had a fractured central incisors. Incisors were fractured, the bridge was gone, and straight away only root stumps were remaining. So this CBCT image, the 3D panoramic reconstructed image, is the basis of my treatment planning. Based on this, I have to decide, firstly, implant placement is possible or not. So I see ample bone is present above this periapical radiolucency or the bone loss. I say placement is possible. But what do I require? I require my Lucas bone scoop so that after extraction with luxators, I should be able to curate it properly. Secondly, of course, in order to ensure that my implant survives, I require very good quality bone graft and a membrane. Then only I'll be able to ensure that this case goes smoothly. So what I did was I extracted those teeth and I placed these implants. But these implants, my socket is like this, my implant is in the center. My implants will fail. So now what I had to do was I had to do bone grafting, basically. So this bone grafting, I condensed my favorite bone graft, FDBA and DFDBA from Tata Memorial Hospital, which I can proudly say it has been 20 years. This year I completed 20 years. The first case I had done of Tata Memorial bone graft was in May 2002. And now it is December 22. So, but the problem is this graft will spill out. It will come out from this area, this window. So what do I need to do? I need to put a simple collagen membrane here so that it is retained in that area. So please understand, no amount of diagnosis can replace your surgical skills as a periodontal surgeon or at least as a general dental surgeon. All this would be a waste if I'm not able to achieve primary closure. So primary closure is a must, otherwise it will fail. Another thing, can I do immediate loading? Not at all. That quackery exists only with regard to dentistry. Do we go to an orthopedic surgeon with a broken hand and that person says, that orthopedic surgeon tells us, I'm a very good orthopedic surgeon. Now I've fixed your hand. You can go home and lift a bucket straight away with that thing. No surgeon in the world will tell you that. Person will say some period of immobilization is required. So no immediate loading. Maryland prosthesis is the key. So Maryland prosthesis was given. This patient was 82-year-old when I had operated on her more than 8 years back. And in just 4.5 months, this much amount of bone formation was seen. So once I started with the second stage surgery, I gave an incision. I started reflecting the flap and this was my results. Not only the implants had survived, bone had grown over the implants. I had to pick up a carbide burr and expose my implants. So this is one thing which I want to firstly emphasize, that diagnostic modalities can only be an assistance to you in your surgical skills. They won't be a replacement of your surgical skills. But in this case also, everything began with planning. Everything in life happens twice, meaning first in our mind, then actually in our actually in reality. So again, what happened here was, because I had a beautiful CBCT image with me, ultimately I was able to do that thing. So image, it was an implant placement which was an issue in this case. It was what happens after implant placement. How good my bone grafting, how good my membrane placement skills, and finally how good my flap approximation and suturing skills are there. So please understand, CBCT is an asset to an extent. Don't get played by what these companies are actually guiding you, that you can do it blindfolded. No, that happens only in movies. Okay, so let us start with a small history. How did this CBCT come into existence? Is it a new thing? Why are we hearing about it only now? So computed tomography basically meant that sectional images are being taken. Basically, what we are doing is that we are taking separate sections of the tissues so that we are able to see everything inside. So in this is not a new thing. This was developed way back in 1967. This was the first CT machine. Sorry, it started first as CT in 1967, CT. And in that CT, this was developed by Sir Godfrey Hounsfield in 1967. So this is not a new discovery. However, CBCT came much later. CT came earlier. So computed tomography is the machine that we have in our Subharti Medical College. And ultimately, we moved on from fan beam, that is conventional spiral CT, and we developed cone beam also in addition to conventional. So medical side, this is the one which is mainly used. And in dental, this is the one which suits our needs as such. So cone beam computed tomography was developed, and this is just a small video. I hope it gets played and you are able to hear the sound. So just 2 videos I have incorporated so that as a layman, we can understand how CBCT is different from CT. So this video is about, very short video, is about CT. So let me know, the host, if after the video, we were able to hear it or see it. So I'll just play based on my net connection.
CT images are more detailed than conventional X-ray images and can reveal bones as well as soft tissue and organs. Conventional X-ray uses a fixed tube that sends X-rays in only one direction, while a CT scanner uses a motorized X-ray source that shoots narrow beams of X-rays as it rotates around the patient. There are special digital X-ray detectors located directly opposite the X-ray source. As the X-ray passes through the patient, they are picked up by the detectors and transmitted to a computer. Image slices can either be displayed individually in 2-dimensional form or stacked together to generate a 3-dimensional image that can reveal abnormal structures or help the physician plan and monitor treatment.
So first and foremost, was it audible and visible? The host.
Yes, sir.
Okay, thank you. This is what I would like. So the important thing is, did you notice a single beam in a single plane? That is what is conventional CT. It takes time. The beam is going at a single plane, and that plane is basically the x-axis. That is, it is the axial, or basically it is the transverse plane. Now, this is where CBCT is the more advanced version, because the axis, instead of just one, it is 3 axes. All 3 planes I'll be covering up. It is not just the axial or transverse, it is sagittal and coronal also. So basically, CBCT scans the body in a 360-degree manner, while CT scans it in only one direction. So it takes more time for CT rather than CBCT. So basically, we have to remember that ultimately 1.5 decades, 15 years after CT, CBCT was developed. And initially, it wasn't developed for dentistry. 82, it had come for angiography. But of course, later on, more advanced investigations came in angiography, and it wasn't used that frequently. But it was in 88, way back in 88, it was introduced in dentistry. And that is when it started having a lot of applications. But the issue was, in the beginning, it wasn't the CBCT that we know now. This was the first CBCT image which was produced. Can you see? It is almost like a pencil drawing. So it wasn't much helpful that time. But over the years, it got advanced. And now it has become part and parcel of our practice. In that also, please understand the reason it has become, I'll just show you. The reason it has become part and parcel of our practice is because after implants, basically what happened was we were able to justify the cost of CBCT. Before that, as a small-time practitioner, if I charge just 2,500 rupees for a single root canal treatment, I cannot say get a CBCT examination done of 2,500 rupees only, meaning the diagnosis is costing almost as much as the treatment. So the reason why CBCT, all this talk that we hear in dentistry, is because of the success of implants. Without implants, you cannot justify, at least in small cities like ours, the cost of the diagnostic modality. You can show it, take it up as a research thesis in a college, etc., as such. But the point is, you cannot justify it in a clinical setup. And now, just half a minute short video, please appreciate how CBCT is different from conventional CT. So just have a look at this video. This is my last video, don't worry. Okay, so
in CBCT imaging, the X-ray source and image detector rotate 360 degrees around the patient's head. Depending on the clinical site of interest, a region of the patient's head is exposed to the X-ray beam. As the rotation occurs, a series of two-dimensional basis projections, also known as frames, is captured by the image detector. The complete series of these frames then comprise a three-dimensional anatomic volume. As seen in this video, the region is the whole head.
So can you see, this was the difference. This was the difference, which I wanted to ask Vipin Pandey, but Vipin Pandey has gotten up. I don't know why. Vipin, can you hear me? No, okay, so it's busy. So please understand, this is the basic difference between CT. CT was a single plane. Here, basically, it is 360 degree. So more area is covered in this thing. Okay. So these are the differences that you have to be clear in your mind. So Vipin is standing and the PGs are standing. I think the teacher has come. So I don't know whether I'm audible or not to them, because they are not responding as such. Not an issue. I hope the audience was able to hear this thing. So Vipin is still standing. So not an issue. So please understand one thing. This is a more advanced modality than conventional CT. And we have five advantages of cone beam over the medical CT which is being used. The first, of course, I have already covered. The radiation exposure actually is much lesser with regard to a single section, 40 to 60 times lesser than conventional this thing. Okay. The second thing, please understand, it is a much faster modality than CT. It takes less time. In a single rotation, more is captured. In here, multiple slices are required. Both arches can be captured simultaneously. Here, it can capture only one arch at a time. Scatter is less. CBCT is safer as compared to conventional CT, and it is much more easier. The positioning doesn't have to be that accurate as compared to a common CT. Okay, so this is one thing. Two terms which we are supposed to be aware are pixel and voxel. So as in a nutshell, as a layman, I can only tell you that pixel basically is two-dimensional, voxel is three-dimensional. So an image size is basically measured in voxels if you are referring to a three-dimensional modality like CBCT. It would be measured in pixels if you are referring to a two-dimensional modality like RVG, etc. So as a student, I can see few students writing down notes, etc. So Vipin Pandey, I think now he can hear me. Nobody can hear me. Only the host can hear me. Is it Vipin Pandey? Their name is...
Sir, every participant is on mute.
Is on mute. Okay, so they cannot respond. But even by this thing also, they are not giving this thing. Not an issue. Thank you. So please understand, voxel for three-dimensional imaging, pixel for two-dimensional imaging. That is one thing which you are supposed to remember. So with regard to the advantages of CBCT, please understand, firstly, X-ray beam has a limitation. Here, it is lesser as compared to CT, because the field of view, as Sanjay sir already covered, we can change. We can change according to our requirement. So we can reduce the radiation exposure depending on the number of implants that we are placing. The second thing is it is rapid, quite rapid, faster as compared to CT. Display modes are quite unique to maxillofacial structures. The kind of 3D reconstruction images that you get in CBCT are quite good. CT cannot match up to CBCT. So this was the FOV part which has already been covered. So I was just eliminating majority of my slides which were coming in Sanjay sir's presentation as such. But this slide I thought I'll still keep. I have eliminated all my full mouth cases as such. because the cases have been discussed in detail. So this is a large FOV in which the entire face, mainly from a cephalometric point of view, can be analyzed. We have medium FOV, as sir covered, in which maxilla and mandible, basically from sinus lift, etc. we require. And of course, suppose single implant or 2-3 implants or only one side arch is there. This is the restricted FOV that we can use, and we can have basically multiple focused FOVs also. That is, stitch scans can be used from multiple these things. So this is basically important, and this is one thing which can be used. Okay, so these are the things that we need to be aware of FOV. Two other advantages are image accuracy. The kind of images that we get here are quite unique. The kind of images from which actual measurements can be taken. That is the advantage of CBCT. And of course, reduced patient dose is there. So as compared to normal X-ray also and CT also, it is a far more better thing, a more advanced thing that we are able to use. Not only with regard to quantity, it is the quality which can be assessed. So all of us are aware of Misch classification of bone density, which according to different types of wood he had given. The same bone density can be measured with Hounsfield units also. And it has been shown that this measurement is quite accurate. This measurement is quite accurate as compared to a normal actual measurement that we do. So this is basically a thing that we have to keep in mind. Quantity as well as quality we can get to know by CBCT. So there are 4 components of any CBCT image production. We have acquisition, then we have image detection, then we have image reconstruction, and finally the display. Anything going wrong in any of these 4 areas will be affecting your final CBCT image. So these are the things which are there. And finally, software programs are the ones which actually give us the entire thing. They give us reconstructed images, they give us bone measurements, etc. And this is where our first mistake with CBCT starts. What happens is we straight away start relying on the software blindly. And this is where we start becoming lethargic. And ultimately what happens is that suppose we are relying on it blindly, this is where our practice starts suffering. So we straight away start relying on a piece of paper, which happens to be the CBCT report. No. So the important thing that we have to remember is that CBCT is a very, very good, very advanced, essential diagnostic tool in our armamentarium. But the report we have to read and understand ourselves. So just 5 minutes I'll take how to read a CBCT report. Any person who wishes to incorporate basically implants in his or her practice cannot rely basically on the piece of paper which is given by a radiologist saying that this is the report and this much implant you should be placing. Please understand, this is an adjunct. This is not a replacement of either your clinical surgical skills or your clinical decision making. This can only help you in decision making. This cannot be a substitute basically of your surgical skills. So these 3 reports, many times they give you 2 reports, PDF images, are part and parcel. So I've just taken at random this case I selected just now. This was 2017 case. So this was basically a case which has been done little over 5 years back. So the first part of the report is 3D panoramic reconstruction. So please understand one thing. If you want to justify the cost, this is what I always emphasize, that something which is limited to only the college setup and you are not able to incorporate in a small town practice is of no use. So you have to justify basically the cost to the patient. So ultimately what happens is, if for the last 18 years in my practice, I have been charging only 18,000 per implant with prosthesis on a single tooth basis, I'm telling, I cannot still say that 2,500, that is the thing that they charge in Meerut, you have to get a CBCT done. No, I have to involve the patient in the decision-making process. Otherwise, the patient will say that, doc, this should have been part of the procedure only because this is your requirement, not ours. And secondly, God forbid, if the report doesn't come positive, the patient will feel that 2,500 rupees were lost. So please understand the economics of the trade. This 3D reconstructing image is basically for patient motivation. Once you have to convince the next patient to get a CBCT image, you have to show the 3D reconstructed image of the previous patient to this person, saying that this is the advantage of getting a CBCT, that even without raising a flap, you are aware that where are your vital structures, how much bone you have, and whether or not an implant can be placed safely or not. Please understand the word safely. Implant or any dental surgery is safety first. Once the patient is convinced and gets a CBCT done, this is your main file. This is the bone measurement file, which all of you have to be aware how to read. So this is how this thing comes. The report comes, which at times straight away we are quite perturbed. So what happens is that we actually are quite perturbed that whether to how to read this thing, and straight away we say leave it. We'll just pick up the paper and we start reading this thing. So this is one thing which I miss in online teaching. So can few of the participants switch on their cameras if possible, if they are there? Or I think it is only the me and the host speaking. So even Pandey has switched off this thing. So Mayank sir has the camera on. Good. Okay. So this is one thing. Thanks a lot, Dr. Neha, ma'am. So few people have the camera on. Good. So otherwise what happens is I feel as if I'm speaking to myself only. So trust me when I say that many a times, majority of us don't know how to interpret these images. No, that is wrong. So please understand these sections. It will just take 2 minutes and I'll be as brief as possible. This is how the report has come. Please understand this section. So what is this section? What do you call this section? Transverse, axial, sagittal. So please understand, we have 3 sections in CBCT. We have, suppose I cut my jaw like this. This would be basically the transverse or the axial section. If I have a mandible and I cut it like this would be the sagittal section. So axial section is something which cuts the part into upper and lower part. Sagittal section is the part which cuts it into right and left. And finally, coronal section is the one which cuts it into front and back part. This is a basic thing. So now if this thing comes, suppose I'm saying this section. So this section is what? This is the transverse or the axial section. Axial section means it has been cut in a horizontal dimension. This section is the one which will guide you which section to examine in your CBCT report. And again, it is pretty easy. All of us can appreciate this empty space. All of us, as a layman, we can say that I need to place my implant in the center of this empty space. So let's say 1 to 12 or 14. The center would be roughly 7. I want to place my implant at number 7. So now from this transverse section, I have decided that I want to examine 7 number slide in all these slides which have been given. So these slides are which section? If it is an anterior tooth and I wish to know the bone thickness, it would be called as a sagittal section. I cut it like this. I'll be able to know the width of bone in the anterior region. Anterior sagittal. As the mandible curves like this, if I have to know the width in the molar region, my section will change to coronal. So posterior, if I want to know the width, it would be called as a coronal section. So now I have to evaluate in this molar the coronal section number 7. So number 7, if I enlarge, this is how number 7 section looks like. It is telling me width is 10 mm and the height is just 7 mm. This is where the third part of the report is something which you don't have to pay much attention to. This is what the radiologist is advising as a non-clinician, that what you have to place. So the radiologist had advised me here 3.4 into 8 mm. So this is one thing which I cover up in my implant lectures. Here I have just restricted to the imaging part. Please understand, never ever place an implant this smaller width with this smaller length, because the BIC would be quite less. The width has to be more at least. So instead of going ahead with this thing, in the same patient, I had placed 5 millimeter into 10 millimeter implant with indirect sinus lift in this case. And it has been more than 5 years. It is surviving easily. This was a latest case, which not a latest, but a midterm case, which I had included. Okay. So just 3 cases total I have included. The remaining I have excluded all the along with the theory. So please understand this report as an implant practitioner, you have to evaluate yourself on your iPad, computer screen, wherever. Do not be a sort of an uneducated person. Okay, do not be taken up by what these companies are offering you. They're offering us stents. Blindly place an implant. They are offering us something else. This thing will be done robotically. Nothing will be happen robotically, at least not during our lifetime. You can take it from me. So please understand one thing. You have to look at the biological side of things, not the commercial side of things. If you don't know how to read a simple CBCT report of a single tooth missing, how do you expect to be proficient? How do you expect basically to know about something which is supposed to be, what do you say, supposed to be more advanced, full mouth rehab? That is something which straight away we talk about. So this is basically the CBCT machine that we have in our college. We normally get it done from the city also. This is the analyzing unit that we have there. Okay. So after this thing, basically, this is the report that we get. Okay. So please understand one thing, that CBCT at no point of time can replace your chairside imaging. So during implant placement, again, your RVG plays a major role. So this is just a point which I'll be touching as such. Please understand one thing, that CBCT is a pre-diagnostic tool mainly. It will help you in deciding whether implant can be placed or not. It will help you in deciding the sizes of the implant which can be placed. But it is not a replacement for chairside imaging. So chairside imaging, thanks to RVG, has progressed a lot. All of you must have heard of the notion which we used to hear when our PG had started in 2002. For implant placement in the posterior area, please do not give a nerve block. You won't get to know when you are approaching the nerve. Absolute bullshit. Please understand, all these things are things before digital radiography was invented. If you cannot appreciate digital radiography, that is two-dimensional, your normal RVG, definitely you cannot appreciate CBCT. And again I say, something which you don't understand, something which you are dependent on a company fellow to tell you that this is this, please don't incorporate that thing directly in your practice. We as doctors, dental doctors, are supposed to have much higher IQ than these company people. So what we are supposed to do is we are supposed to use that IQ. So RVG is a must basically, and always give blocks, nerve block, that is when you are placing implant. So the basic thing is that CBCT is not a replacement of chairside imaging. Please understand. The chairside imaging, that is the radiovisiography, this is the unit that we have here. The clinic part I haven't included because I'm delivering my lecture during duty hours, that is college hours. These images will tell you firstly whether the angulation is correct or not. Secondly, they will basically tell you how far away from the nerve or any other vital structure you are. This arrow is reverse. This for the sinus basically that I wanted to include. So these are the things which will tell you whether you are going accurately or not. So again, I said, implant is surgery first, prosthetic lab work is much later. Okay, so please understand one thing, that always and always it is surgery means safety. If you're not a good dental surgeon, no matter how many shortcuts these companies are telling you, we are many a times, few of us have not actually taken dentistry by choice. So few of us are there who wanted to take medical. And because we didn't get MBBS, those of us, few of us, not me, I had left MBBS in 96 in Manipal and opted for BDS. We are pushed towards the dental side. So now we are obsessed with whichever imaging modality has come in medical side, and we want to incorporate it blindly with regard to our practice, irrespective of whether it is required or not, irrespective of whether economically it is feasible or not. So suppose a person, a cardiologist, is doing an angiography. It is his need that he needs that real-time imaging. Many a times we don't require that imaging. Our clinical experience, surgical experience can actually substitute for this thing. But suppose we want to incorporate, that is good. But what I want to emphasize is at no point of time that real-time imaging will be a replacement of your clinical surgical skills. Your clinical experience and surgical skills will be at the paramount, no matter what new advancements are there in these imaging technologies. So again, correct guidance is a must. CBCT guided stent. Please be very, very, very careful. Whenever we have more number of steps involved, more number of steps means image has to be captured first radiographically by CBCT. First step, any problem in the capturing part might be there. Second is it has to be analyzed by a software. Second, chances of software glitches, all of you are aware of software glitches. The third is a stent has to be fabricated by a lab. Shrinkage, etc. might be there. So there are ample and more cases here. Few of the labs, at least me and my oral surgeon Prajesh. So we took a stent and we started placing multiple implants. And according to the stent, the implant was literally going out of the jaws, out of bone as such. So please understand, all these are adjuncts, not alternatives to your chair side decision making. Please understand this thing, okay? And anything which you cannot economically justify in a practice, that means you have to learn a way to incorporate the essential component of CBCT, and maybe the additional component is something which is an option for us, okay? So these are how stents we used to make earlier. So the first research under me was in 2013. This is how we used to make stents earlier. These were surgical stents basically, but here the issue was buccal side was completely blind. So my students whom I used to train how to place implants in a patient, they used to go blind. They never were able to see where that drill is going, whether it is hitting the bone, soft tissue, etc. So ultimately, I told them, please drill, please remove that thing from the buccal side. And this was a simple arrangement that we did basically. So this is what, this is stent guided, surgical stent guided surgery. Now we are able to see it in this thing. Of course, this is more important with regard to multiple teeth than this thing. So please understand one thing. Is CBCT always accurate? Again, incorporating it should be there. Should be there. But what did I say? Always and always I say it is the man behind the machine. Okay. We have to be smart enough to see when it is not accurate. For example, this particular case. So this was a case, I'll just wind up my presentation. Okay, 50 minutes already. I was allotted 45 minutes total. So I'll just take 2-3 minutes more. I'll just wind it up fast. This case, a young patient, 18-year-old, he had a trauma and his 4 central incisors, root resorption had occurred. They were quite mobile. They had to be extracted. And because of that trauma, a lot of bone loss was also there. Okay. So this is just a recent case. Hardly, I think 20 days back, I had operated. So I've taken a slightly older case, which I operated 8-9 years back, then slightly newer 5 years back, and something which I operated within the last month or so. Just 3. I am not here to showcase my work. Please understand. I'm here so that those of you who are giving me this honor of this time of yours in your peak college and peak practice time, 2-3 things I should be able to share with you so that I can also learn from your experiences. So this is the CBCT report. So CBCT report told straight away, 4 implants have to be placed and 4 implants can easily be placed. I had my doubts. I had my doubts because I had clinically examined the case. So what happened was, in spite of the CBCT telling, dimensional inaccuracies can be there in the CBCT. Please understand this thing. In spite of this thing telling that 4 can easily placed, when we actually took the cast, physical measurement, again, what you see, you have to believe. You cannot say that this software is better than us. No. Once we analyzed the cast after removing those teeth, no matter how much we tried, there was space for only 3 implants, although not in prosthetic position. So what determines this position of the implants? A basic clinical tip of biologic width. So biologic width says it very, very clearly that between the implant and tooth, 2 millimeter has to be there, and between two implants, 3 millimeter has to be there. So this is a basic tip which we have to follow. No software can replace biologic width. So biologic width, if it is there in natural teeth, this I cover up in detail in my lectures on periodontal surgical considerations in implantology. Please understand biologic width requirement, if it is there in natural teeth, it is even more in implants. Firstly, biologic width violation has some implications around natural tooth, but because of a powerful tissue like periodontal ligament, it gets compensated to some extent. Here, no PDL is there, it is disastrous. So ultimately, this 3 millimeter distance between the implants has to be maintained. So what happened was, we started with the case, this was the incision part. So after incision, again, we started reflecting it. Once the reflection was done, with luxators, I ended up extracting the teeth. Can you see the amount of root resorption? Now the problem here is, no matter how much you try atraumatic root extraction, the very fact that root resorption has occurred, that means what? That means basically bone tissue has replaced more or less roots. So that means ankylosis would be there. So the moment you take out an ankylosed tooth, some amount of bone comes out with this. So ultimately, this was the shattered site that we had. From the cast, we know 4 implants cannot be placed because biologic width would be violated. 3 implants doesn't make any sense because they were in prosthetically wrong position. So ideally, implant should have been placed here and here in the lateral incisor, acting like a bridge. But the bone was completely shattered here. I had two options, either to go deep in the lateral incisor area. In that case, my crown implant ratio in this case would be totally disturbed. This is another thing which many clinicians are obsessed with. Immediate implant placement at the cost of crown implant ratio. So crown root ratio is 1:1. Crown implant ratio is supposed to be 1:2. But what we do is, many times, a few oral surgeons also do this mistake, that once a tooth has been extracted, they have to place an implant. No, never ever go deep. Either change the position or go in for socket preservation. Fill it up with a bone graft, place an implant 3 to 4 months, maybe 5 months later on. Okay. So hence it was decided these are not ideal positions. So I went in for a compromise. My priority now was implant survival first. And ultimately, I placed implants. This was the drilling which was done in the central incisor area. And once the drilling was done, I started placing 2 implants here. This is just a small case which I have included to tell the point where CBCT can go wrong. And finally, these were the implants which were being placed. So these are the implants which were being placed in the central incisor area. And now these were the implants which were placed. So you can appreciate it from this angle. Can you see? The final prosthesis would be 2 central incisors with small cantilever in the lateral incisor area. So again, as far as possible, avoid cantilevers. But given a choice, again, if in case you don't have a choice and the patient wants the implant that time only, this is how we have to deal with it. The important thing which I want to show is that in this photograph, it is quite obvious. It is quite obvious that we don't have space. We didn't have space for 4 implants as told by the CBCT report. So please understand, in this, it is appearing wider as a 4. Now cover screws were placed. And of course, my favorite bone graft again and again, Tata Memorial, DFDBA if possible, otherwise at least FDBA. So this is a beautiful bone graft which I always prefer in all my implant cases, especially in cases of immediate implantation and my cases of GBR also. Allograft, going for allograft as far as possible. Autogenous bone graft quantity is an issue. Xenograft, okay, compromise, avoid alloplast at all costs. So this is something which I cover up in detail on in my lecture on bone graft. But as of now, DFDB, we put it properly. But then again, after you have put it properly, the most important thing is primary closure. If primary closure is not there, that is when everything is a waste. So please understand, primary closure. Here I have used PGA PLA sutures. So just as the time was getting extended, I have just removed a full mouth case of mine. Not an issue. In any other lecture, I'll demonstrate that also. In that also, I have emphasized why GBR. I had emphasized why GBR is part and parcel of immediate extraction, especially in the maxilla. Here, no GBR was required. Here again, few people have a lot of doubt. If bone graft is placed, you have to place a membrane. It is not like that. And trust me here, what will a stent give you? Implant placement has been done. The remaining is basically your skills. But as far as possible, ample and more literature is there which shows that CBCT is something which is a boon. So CBCT you have to incorporate in your practice. And again, CBCT has revolutionized implant dentistry. It has revolutionized because after implant dentistry only, CBCT actually came in the limelight in dentistry. Initially, no matter how much we were telling that some extra canal might be there in the tooth, please go in for CBCT, etc., it wasn't actually justifying. It wasn't actually justifying the cost, the economic feasibility, because the entire treatment procedure of RCT wasn't that expensive. So again, as far as possible, we have to go in for CBCT, especially with regard to cases where inferior alveolar nerve, etc. is there. So again and again, I'm repeating, it is safety first. Safety first basically means what? That as far as possible, no vital structure has to be damaged. Okay, so this is why again, I'm not in favor of this thing, basal implants that much, because again, in a practice, the rule is keep bravery and practice separate. So anything which is more invasive has more chances of damaging the vital structure. So again, this thing is there. Last point which I want to emphasize is that many of us feel that CBCT is something which is only a pre-diagnostic tool, pre-surgical tool, not at all. Please understand that once post-surgery, if this thing is persisting, if pain is persisting and you feel that you have violated a vital structure, or if you feel the implant is failing or some pathology is there around the implant, even post-surgical, to evaluate any encroachment of the nerve, etc., to see whether the bone loss is there around the implant, etc. Post-surgical also, we have to get CBCT done to see how much bone graft was retained in the site, etc. We have to do. And again, from a documentation point of view, if you want to show that how good your regeneration was, it was there. Okay. CBCT, again, one thing, it is not perfect. Please understand. So there are a lot of stages, be it in the cone beam geometry, detector sensitivity, or construction resolution, where things can go wrong. The report which I showed, that was just one example in which the physical measurement had gone wrong. But otherwise also the images might be unclear, etc. So never ever think that it is a complete tool in which can actually replace the clinician. So this is not the case. So again, to conclude, okay, exact 1 hour I have taken. So conclude, I would like to say again that very essential tool. My practice changed drastically, at least from 2008 onwards, when I started incorporating CBCT in my practice routinely. So 2008 was the year, 3 years after I had begun my implant practice in 2005 in Meerut, that CBCT actually started here as a routine modality. 2008 onwards, it has been just 14 years since I've been using CBCT in my practice. It is a big jump. It is a big jump. Okay, there are cases in which you don't require it, but there are cases in which bone is less. If you were to take it, it is a non-invasive aid that will actually revolutionize your practice. And again, it is not a replacement of your chairside imaging at all. You need imaging. And of course, the eye doesn't see what the mind doesn't know. It is always and always the man behind the machine. Okay, never ever think that CBCT will be a replacement of your skills as a clinician. We are and we will remain the real heroes in at least decades to come. There are things which, let's say robotics, there are things which advances in technology can replace. There are things which it cannot. So suppose automated dentistry has not even entered a simple cavity preparation and restoration in a superficial caries. I feel it is decades before it will enter invasive dentistry, surgical dentistry. So those days are still this thing. Never ever use CBCT or any other this thing, incorporate it, but your surgical skills and your chairside decision making and your chairside imaging will remain part and parcel of implantology. So again, if you wish to see our cases and my cases also, I'm there on Facebook by the name of Dr. Mayur Kaushik. We have our this thing also. Instagram, again, I keep on putting my cases routinely on Instagram by the name of Dr. Mayur Kaushik. You can just have a look at those cases also. So basically the cases which we emphasize upon is that in second stage also going for the conventional surgery. And this is the department page, Instagram page. We have our YouTube channel also. So if you want to see if you want to learn the basics of implantology, types of physio dispensers, if you want to learn about types of implant kits, what's the difference between a toggle ratchet, a toggle type of ratchet, and a beam type of ratchet, etc. All that I have covered up in our YouTube channel. It is there for free. That is part of our Seva part. So again, I would like to say the same thing. Thanks a lot, Monali ma'am, for considering me worthy of this honor. It is something. I'll just stop the sharing first. Thanks a lot for the honor. Mine was just a basic presentation. I'm a small-time practitioner. I emphasize more on basics. And whatever I cannot economically incorporate in my practice is something which I don't propagate, I don't recommend much. So again, there's a huge difference between, depending on the city of your practice, a metropolitan or a small town, etc., in which how we propagate our ideas as a clinician. As a dental surgeon, IRS is the key. And again, implantology will always be a surgery done by a dental surgeon. And finally, the prosthesis part being held by a lab technician. This is how it will be in the future. So thanks a lot again, all of you. And thanks a lot for being such a patient audience. I hope all of you were there as such, meaning the cameras are off. Thanks a lot, Mayank sir. I could see Mayank Gupta sir the entire time. That time I couldn't see. Thanks a lot, sir. Actually, I am this thing who likes to see people while speaking. Otherwise, I cannot speak only. I get sleepy. Thanks a lot, Dr. Ashwin. I can see Ashwin now. Vipin Pandey has gone. I don't know why. He was there initially. Then I started calling his name. He ran away. He was there sitting with a bunch of people. So I thought an entire class was listening. So thanks a lot, the organizers, for being patient in my 1 hour, 5 minutes presentation. Exact. I always try to time the presentation. And thanks a lot again, Monali ma'am. Thank you. Thank you. Organizers. Okay, organizers are not there, I think. Okay, they are there.
Thank you so much, sir, for the amazing session. If anybody has any question, kindly mail sir or put it in the chat box or in the YouTube comment section.
How to decide the width of the implant size if the section of CBCT shows different widths? Excellent question. Excellent question. So please understand, never ever rely. I never ever rely. I'll address the first question first on what the CBCT size of the implant is telling, meaning the size of the implant which the CBCT is telling. That is the first rule of becoming a successful implantologist. Don't look at it at all. Just look at the bone measurement file. That is the key. Okay. Now, when it comes to implant size, that you have to decide keeping the 1, 2, 3 rule in mind. That is, suppose the width of the implant, the bone, is 6 millimeter or so. Once we place an implant, minimum 1 mm of bone has to be there on the buccal side, 1 mm has to be there on the lingual side. That has to be the width. 2 basically means that 2 millimeter of bone has to be there on the mesial side from the tooth, 2 millimeter from the distal side of from the distal tooth. And 3 means that minimum 3 mm distance has to be there intraocclusally. So based on bone dimensions and based on mesiodistal width available, you have to go in for the widest possible implant. And based on length available, you have to go in for longest possible implant. But one thing you have to understand, Mish says it very clearly, BIC, bone implant contact, is the one which will decide how much your implants will be surviving. Meaning, BIC means bone implant contact, width is more important than length. So suppose I follow a general rule that 4.2 into 10 mm implant will be sufficient for my molar tooth. But because, again, I say India has lot of patients, but doctors don't have patience. So whenever they are trying to extract a tooth, they try to show that I am an expert dentist by taking out the tooth as fast as possible. So they end up doing chiseling, etc. So width is something which we don't get. So if I am not able to place 4.2 into 10 millimeter implant in the molar area because width is less, and I have to go in for 3.75 millimeter diameter implant. From 4.2, I have reduced it by 0.5 millimeter. I need to increase the length 3 times more. From 10, I have to increase it to 11.5. What did I say? Width reduction by 0.5, length increase by 1.5. Why? Because it is clearly told in textbooks that 1 millimeter increase in the width increases the BIC of the implant by 30%. On the other hand, 3 millimeter increase in the length increases the BIC by hardly 10 to 20%, depending upon whether it is an active implant or a passive implant. So active passive, I'll just tell. So width is more important than length. Many times we are obsessed with length. We feel longer the better. No, if you are getting width, even if you place a 5 millimeter by 8 millimeter implant, 5 millimeter width, 8 millimeter length, that will be sufficient. But if you are forced to reduce the width by 0.5, 4.2 to 3.75, increase the length of the implant by at least 3 times, 1.5 mm. First thing. Okay. So BIC is one thing that you have to keep in mind. Section, you have written Astha, section 5.2, section 4.4. No. See, you have to reduce 2 millimeter from whatever section has been given. Okay. So suppose the section is 6, the maximum width is 4. But at the same time, it is a machine. So again and again, I've grown up seeing Terminator movies, machines taking over the world. It hasn't happened till now. So artificial intelligence, no. Machines are something which have errors. You keep 2 implant sizes, 6 millimeter, you keep 4 millimeter, you keep 3.75 also, or 3 also, not 3 for molar. And then you decide the size after reflection and actually measuring the width. Then you decide something which is 2 millimeter lesser than the width. Is that part fine? This thing has stopped, or Astha has stopped? Astha has frozen. Astha Devnath. She's
Sir,
not.
the mic is muted.
Her mic, okay, but otherwise she is able to hear. Okay, so but they are not nodding also. How come? The picture is also muted somehow. Okay, so she has gone only. Okay, so that means the question was answered. Fine. So the last question is, which implant system to use? So please understand, first are implant system based on microstructure. Microstructure means whether it is active or passive implant. Majority of the Israeli systems, Alpha Bio, Adin, and then Impact, Bioline, etc., they are active systems. Active systems basically means that the thread design, this I cover up in detail in my implant lectures, the thread design, the thread pitch, distance between the threads is more, and the thread depth is more. So active implant systems are something which I normally prefer. I find it easier to place, means the thread design is such that it is self-drilling. I can easily place it in immediate extraction sockets after minimal drilling. These are active implants. But active implants, basically, you will prefer their BIC, bone implant contact of these Israeli systems is lesser because the threads are wider apart. If you shift over to Korean systems, Dentium, Ostem, etc., those are passive implant system. So passive implant system basically means what? That the threads are closer together, the depth is lesser, the BIC is more. So suppose my recommendation would be that if ample bone is there, go in for passive implant system in which the thread design is closer together. You'll get more BIC. If bone is lesser and you feel that minimal drilling has to be done, and ultimately you're not using denser burrs or piezo surgery, these are topics which we cover in the implant part, and some amount of bone loss shattering will be there during the drilling process, go in for active implant system, which are self-drilling. So I would prefer majority of the time active over passive. The second thing which we have to decide in choosing the implant system is the type of attachment, whether the abutment which is getting attached to the implant is internal hex or Morse taper. So internal hex would be same, add-in, etc. all are internal hex. Add-in close fit is Morse taper. Then iFix is Morse taper, tapered connection, basically, not exactly Morse taper. Ostem, etc. generally come in Morse taper. So Morse taper basically means that long implants are there, long connection is there. So single tooth prosthesis prefer Morse taper, abutment screw loosening is there. And in multiple systems, because loosening is not an issue, you are giving a splinted prosthesis over 3 implants, you are placing 4 teeth or 3 teeth splinted together. Go in for internal hex implants. Second thing, okay? So internal hex, multiple implants. If you are having single tooth, prefer Morse taper, first thing, okay? So the next thing basically is that last thing, implant surface modification. So when I had started placing implants, they used to have additive surfaces, titanium plasma sprayed, but those surfaces are obsolete. They had a lot of failure. Now we are basically placing sand-blasted, acid-etched, sand-blasted large grid acid-etched implants, subtractive surfaces. So the last category is whether the implant is only rough or whether the implant is biomodified also. So suppose you are dealing with a system like Toreg OS, they claim calcium phosphate coating is there on the implant. Noble Active, they say their surface is active. So active means this implant would be double the cost because they are saying that they haven't made the surface only rough. They have actually added some coating. It might be a growth factor, it might be a simple calcium phosphate, which will enhance bone formation on the implant surface. Ostem also doesn't reveal, but the kind of results which I get with Ostem, those are basically, it is biomodified. So again, Perio, at least 8 dissertations under me have been over on biomodification, and it works. Okay, so please understand one thing. 3 types you have to decide, active or passive, type of connection, whether Morse taper or whether it is internal hex. And the third type basically is whether it is simple roughened implant or whether it is a bioactive implant. Okay, be aware and be ready for this thing. Okay, the next question, Dr. Suchit. So Suchit has asked that is ultra short implant with 5 mm length advisor? No. See. This question, please understand. The moment you have decided to go in for sinus lift, naturally you will be placing a wider implant. As far as possible, you are dealing with a nightmarish situation. If I am talking from D1 to D4, D1 bone is mandibular anterior, most dense. D2 bone basically is mandibular posterior. D3, less dense, is maxillary anterior, and D4, least dense, is maxillary posterior. So maxillary posterior already has the weakest bone available. Now in that weakest bone, what you are saying is place a shorter implant also because height is also less. So please understand, 5 mm I will never advise. I frankly avoid implants less than 8 mm. Okay. In case less than 8 is available, bone height in the sinus area, try to do a sinus lift. Okay. Because for the success of a 6 mm implant length, the width has to be 6 mm. You don't get that sort of width in Indian population. And still with 6 mm width, some amount of bone loss means hardly 5 mm of the implant is inside. No. Ultra short implants, as far as possible, please avoid. For me, the definition of my short implant is 8 mm. I routinely place 8 mm implants. Less than 8 mm, I prefer actually direct sinus lift more because with piezo surgery, I prefer a direct approach. Please go in for sinus lift. Do not place implants lesser than 8 mm. Okay. How to go in for submerged or non-submerged? Always go in for submerged implants. Always go in. Anybody, any company fellow offering you shortcuts, anybody trying to make you a ninja fighter, you can place an implant blindfolded. Okay. Don't get carried away. Don't get carried away. Any company offering you this thing, flapless, I'll give you a tissue punch. for second stage surgery also, and for placement of implant without raising a flap. Absolute bullshit. I'm sorry to use the term. Please understand, always and always bone submerged implants, always and always raise a flap. What did I say? You have to be a good dental surgeon first before you become a good implantologist. Dental surgeon means you have to be proficient with IRS. Okay, you have to be good at flap surgery first. Always place your implants subcrestal, soft tissue wise also, and bone wise also. Okay, there is nothing. Avoid non-submerged implant. Always going for two-piece implant. That would be my suggestion. Okay, I think that's it. Okay, so that's it. So the video.
Yes, thank you, sir. Let us appreciate Dr. Mayur Kaushik sir with an e-certificate for sharing his immense knowledge with us. Thank you, sir.
And just
It
one
was a
second.
great session and a great question answer session as well.
Thanks a lot. Thanks a lot for the honor. And thanks a lot. I can see ma'am now. Thanks a lot, ma'am.
Yes, sir. Thank you, sir. Thank you so much, sir.
Most welcome, ma'am. Most welcome. Honor for me, ma'am. Honor for me. That's it, ma'am.
Yes, sir.
Okay, okay. Thank you, ma'am. Thank you. Thanks a lot, everybody. I'll just take your leave. Thank you. Jai Hind.
Thank you, sir. Everyone is requested to kindly fill the feedback form with the help of the link shared with you in the chat box as well as in WhatsApp. This certificate will only be issued after the feedback form is filled. Now, I would like to invite Dr. Sujit sir for scientific report and for giving more thanks.
Good afternoon, one and all. It's my privilege to present the scientific report and vote of thanks on behalf of Department of Periodontology. It was a wonderful webinar on the topic of radiographic interpretation for implantology. We have got the tremendous response from all over India, and we have got more than 250 participants who have registered for this webinar. And it was very well delivered by our esteemed speakers. And I would take this opportunity to thank our respected speakers, Dr. Mayur Kaushik sir and Dr. Sanjay Jain sir, to share their expertise and tremendous knowledge with us and help us to have better understanding regarding the radiographic interpretation for implant placement. Now, I would like to thank Honorable Founder President Sumandip Vidyapith, Dr. Mansukh Shah sir, and Honorable President Sumandip Vidyapith, Dr. Dikshit Shah sir, for providing us platform to learn. I would also like to thank Honorable Chancellor Sumandip Vidyapith, Dr. Harshad Shah sir, and Honorable Vice Chancellor Sumandip Vidyapith, Dr. Rajesh Varani sir, to create an opportunity for us to learn. I would like to extend my gratitude to Registrar Sir Sumandip Vidyapith, Dr. Chandramani More, and our own respected Dean Sir, KMSR Dental College, Dr. R.V. Subramaniam Sir. And also, I would like to thank the respected officials and IT department, Sumandip Vidyapith, to help us conduct this webinar. I would like special thanks to postgraduate students of our department for helping in smooth functioning of this webinar. Lastly, but not the least, I am grateful to each one of you for joining us today and making this national level webinar a great success. It was a great learning opportunity for all of us, and I expect you all to join again with us for future webinars. Thank you all.
Thank you, sir. Thank you everyone for your active participation, which helped us to make this webinar a great success. Please fill the feedback forms.